Hello, hello. பாலாஜி இது ஒர்க் ஆகுது பாலாஜி ஆடியோ.
Hello, mic check. Hello.
Check. அஞ்சு சொன்னா ஹலோ. இரு நான் ஒரே ஒரு யூடியூப்ல மட்டும் செக் பண்ணிக்கிறேன். ஹலோ செக் செக். ஹலோ ஆடியோ வரல. பாலாஜி பாடி வரல தானே? ஹலோ ஹலோ செக் ஒன். ஓகே ஓகே. ஒரே ஒரு நிமிஷம். சொல்லு. ஹலோ ஹலோ ஹலோ. பேசுங்க. ஹலோ ஹலோ செக் 1 2 3 செக். ஹலோ ஹலோ. ஹலோ ஹலோ. இப்போ வருது இப்போ வருது. யாருக்கிட்ட? ஹலோ ஹலோ. எனக்கு செகண்ட் வருது. Hello, 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 hello. Check one, two, three, check. Hello. Check, check. Sound ഒക്കെ check, check. Hello, check. Hello, hello. Okay. Hello, hello, hello. Hello, check. Hello.
Hello, check. Hello, check. Hello. Hello, mic check. Hello, mic check. Hello. Hello, check. Hello, mic check. Okay. Check one. Mic check. Check one, check two, check three, check one.
Check 1, 2, 3, check. Hello, hello. Dear sir. Are you audible, sir? Hello. Hello. Check 1, 2, 3, check. Hello. 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 Hello, 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 hello. Check one, two, three, check. Hello, hello. check. Hello, 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 hello. Hello.
Hello, hello.
and my dear fellow students. I, Samit Iyer, on behalf of the entire organizing team, welcome you all to the first day of CONNAISSANCE 2026, the 8th edition of JIPMER's Undergraduate Research Conference. Research plays a vital role in advancing knowledge, improving clinical practice, and shaping the future of healthcare. At CONNAISSANCE, we hope to bring together enthusiastic students, dedicated mentors, and experienced researchers whose expertise and guidance will be invaluable in nursing the future generation. Over the course of 3 days, we will witness a variety of events that showcase innovation, scientific rigor, and thoughtful inquiry. Now, I call upon stage Mr. Steve Manoj, the organizing secretary of CONNAISSANCE 2026, to give the welcome address. Thank you, sir. A very good morning to all our present here. It is my immense pleasure to extend a very warm welcome to our guest, Dr. Suma Balan, our respected. On behalf of the organizing committee, thank you so much. Truly delighted to welcome you all. Tonight is always good. Sharing your vision behind Connaissance 2026. Now, I would like to call upon stage Dr. Lata Chaturvedila, the student advisor at JIPMER, to address the audience. Thank you, Samit, and a very good morning to all of you here. Um, I first of all welcome my teacher, Dr. Jagdish, who's a surgeon, and you won't believe after his retirement, he's working in a place called Odon Chetram, which is more of a small village hospital. You can imagine the amount of time he spends with the patient and dedication here. So, welcome you, sir. I also welcome Dr. Suma, who's my senior, but more than that, my friend, who will be witnessing her talk. So I won't talk much about her because there'll be a lot of introduction done. And of course, Nishad, our Associate Dean, and Dr. Jagdish Menon, who again are professor in orthopedics and big man in the institute. So welcome. And most important is delegates who come from all over the country to attend this 8th edition of Connaissance. I would like to place on record connaissance was the idea was conceived by the then director Dr. S.C. Parija in the year 2017, and it was the first of its kind in the country. It's an international undergraduate conference, and I think we are very, as JIPMERites, we are very, very proud of this moment. And I'm sure we'll all, over the 3 days, you'll enjoy this conference because it has almost 33 workshops, and these workshops are famous across the country. And Connaissance is one of the events which I think JIPMER proudly celebrates. So I'm sure you'll have a good take home messages from all this. Of course, other than the workshops, we have lot of guest speakers coming from across the country, and two of them have to be a JIPMER alumnus, Dr. Suma and Dr. Shivaranjani, who will be, other than that, we have a lot of other speakers who will be joining us soon. And we have more other events which are always conducted in Connaissance, like paper presentations in innovations, research, and so on and so forth, case presentations. And over years, the events have transformed quite a bit with new event being added each year. So enjoy yourselves. You'll have, I'm sure, as usual, every time workshops get the 100%, I think more than 100% marks for the workshop, which students enjoy. We learn a lot. It's not just about enjoyment, you learn a lot. So, over these 3 days, I'm sure you'll take back good take home messages, and it's going to be an excellent academic extravaganza. One word of caution: I know many of you come from places where you don't have beaches, so be very careful. Pondicherry beaches are quite deep. Don't venture deep into it, but at the same time, you can enjoy the seashore of Pondicherry. Have a nice time, safe time, and enjoy yourself. Thank you once again.
Thank you, Lata ma'am, for your insightful words. We will most definitely try our level best to maintain the spirit of academic curiosity and inclusivity at Connaissance. Further, let us start this 3 day conference with a dance, representing the theme of this year's Connaissance, Ignis Menschem. What an energetic start to this year's conference. Thank you to all the dancers. Now, without any further ado, let us move on to the guest lectures. It is my great privilege to introduce our first speaker of CONNAISSANCE 8.0, Dr. Soma Balan. Dr. Balan completed her MBBS and MD in pediatrics from JIPMER. She later earned the MRCP in pediatrics from the UK and is currently working as a faculty member at the Amrita Institute of Medical Sciences. She is widely recognized for her work in pediatric rheumatology, particularly in autoimmune and inflammatory disorders in children like juvenile idiopathic arthritis and childhood systemic lupus erythematosus. Dr. Balan has contributed immensely to advancing awareness, diagnosis, and the management of these conditions. She is an active member of the pediatric rheumatology academic community in India and is also a highly sought after speaker for both national as well as international conferences. Today, we are incredibly privileged to have with us a clinician, a researcher, and an educator dedicated to improving children's health. Please join me in warmly welcoming Dr. Soma Balan.
Thank you. Actually, if anyone has to say thank you here, it's me. Being a member of this institution, my alma mater, it is my privilege to come here on invitation. Thank you. Can we get the talk going? Yeah. Thank you. So, pediatric rheumatology isn't something that everyone is familiar with. And it is a branch I slipped into by sheer serendipity. So I was thinking that rather than make this a big story with research, I'll make it a very clinical talk today. And I cannot start this talk in JIPMER without tracing my origins here too. So the very first photograph is a month into joining MBBS. We have the interclass competitions. We won ADZAP. And that's me there holding the cup, recognize or not. Below that is my clinicals batch. We were 65 in a batch those days, and so a clinics batch was much smaller. And, you know, one of the Curie days, we took a class snap. The photograph below is the old JIPMER guest house. I was staying in the international hostel yesterday, and the old JIPMER guest house was where my wedding was being planned. Okay, so many good memories from here. And this, of course, is a recent batch reunion. Very proud to belong to the class of 85. So what is it about rheumatology? It's been called the Rodney Dangerfield specialty of medicine, the Rodney Dangerfield of doctors. He was an American comic hero. And his tagline was, "I don't get no respect," because he used to make all these self-deprecating humor kind of jokes. So basically, rheumatology stands for a group of doctors who probably get lack of recognition for their critical, often difficult work in managing chronic and life-altering conditions. And to put it in a single word, when you don't know what's happening with a patient, call the rheumatologist. He'll figure it out. We are the Sherlock Holmes, the sleuths of medicine, if put to say. So this is a very young specialty, very young subspecialty of pediatrics. Interest started only in the 50s. In India, the Pediatric Rheumatology Society of India was established in 2003. And the very first pediatric rheumatology meeting in the world happened in 1976. This is how patients used to look in the old days. And, you know, the OPDs were full of children in wheelchairs jostling around. The deformities, the outlook was bleak in those days. And we moved from pure symptom relief to disease modification. And now we're talking remission. And soon that we will be talking much more. And all this is possible because of the expansion in scientific immunology, in the explosion in molecular biology and genetics, which have allowed us to understand these diseases so much better that we are able to formulate treatments for these patients who otherwise had very, very poor outlooks for them. Okay. This man in the center is Dr. Balu Atreya, the first pediatric rheumatologist of Indian origin. He's a Tamilian and he did his training and he works in Chicago. He's above 90 years of age. The lady to the left of him is Dr. Amita Agarwal, wife of the previous director of JIPMER, Dr. Rakesh Agarwal, who is probably, she's an adult rheumatologist, but she's the first person in India who really steered a development of a pediatric rheumatology society in India. Okay. Not moving. So we can't say that these diseases are rare. There's a significant, number of cases in the world. And mostly in underdeveloped countries have even more of it. But where are the doctors? So, I don't know. It's getting stuck. So the doctors, 80% of the patients are in the lesser developed countries and only 20% of the doctors are there. Okay. And the reverse too. 80% of the doctors are serving 20% of the patients in the rest of the world. So what are the conditions we treat? So we treat juvenile idiopathic arthritis, various connective tissue disorders, vasculitis, inborn errors of immunity, non-inflammatory musculoskeletal syndromes, amongst others. And you have to remember the only reason for the other picture is to tell you that all these diseases are immune mediated. All of you would be at various stages of your MBBS, you would know that the immune system has two main branches, the adaptive immune and the innate immune. And basically these diseases are engineered by either one of the parts of the immune system. So the major part of our therapeutic application is actually controlling or modulating the immune system. Okay. And if you look at guess estimates of these conditions, they're not that rare. There must be at least 4 lakh children with JIA in India, at least 1 lakh children with lupus in India. And so a significant number of patients and very few doctors to cater to them. Okay. Stuck. Into 10. Okay. So when should you want a pediatric rheumatologist? For children with joint pain and bone pain, differentiating the two is important. For children who have joint pain, rash, and multisystem features, and in various types of prolonged fever situations. So, pyrexia of unknown origin, recurrent fevers of unclear etiology, and in chronic pain. So, we are also a major liaison specialty. We liaise with every specialist in the hospital because the organ for the rheumatologist is not the joint. The organ for the rheumatologist is the connective tissue, and that's everywhere in the body. Okay. So it is a distinct subspecialty. Okay. And the diseases are actually different. Some of them are similar to what presents in adults, but the way they manifest and the implications in children are quite different. Because children are growing organisms. The same inflammatory arthritis that affects a growing joint and a joint that has completed fusion, the consequences are very, very different. So that is why you need pediatricians who have trained in rheumatology to manage these patients. And the skill of assessing, because that is what the clinical skill is, what is going to give you the diagnosis. And that is going to change depending on your ability. Children are not small adults, and that is an important fact to register. So again, a lot of the conditions that we treat are not the same in children and in adults. They may be present, but some are far more common in children, some are far more seen in adults. For instance, rheumatoid, everyone thinks of inflammatory arthritis as rheumatoid arthritis, rheumatoid factor positive inflammatory arthritis. But that is a disease very much of adults. In childhood, only 5% of juvenile idiopathic arthritis is actually rheumatoid factor positive. So there are a lot of inherent differences like that. Okay. Can I change it here otherwise? This thing. Okay. And there are a lot of challenges in there. It's a very, very clinical specialty. And there are a lot of history and examination is everything to us, actually. And that is one thing I want to teach medical students. I don't know how much you all are taught the examination of the musculoskeletal system in children. So you have the GALS, which is a gait, arms, legs, spine, and that was created for examination of the musculoskeletal system in adults. And pediatric examination is slightly different, and that's called a PGALS. And this is a very clinical thing. You don't need any infrastructure. You don't, it takes hardly 2 minutes. And this should be something that when you're doing CVS, RS, abdomen, etc. in your patients, you should add a PGALS examination to all your children. And that will help you recognize the abnormal ones from the normal. So I'll just show you very quickly. This is a free video that you can access easily on YouTube. So these are very simple maneuvers and they are screening tests. You can pick up whether there is a problem or not. Okay. Okay. So the first thing is you ask the patient to walk up and down with bare feet. Okay. And then you ask them to walk on tiptoes and on their heels. Okay. It's taking time. Yeah. So this, I mean, I don't have the time to go in detail with you, but these are the simple things. They will actually bring out, if you have, say, an Achilles tendon enthesitis, they cannot walk on the heel. I'll show you that in a minute. Okay. Then the arms, you get them to do a series of very simple maneuvers like outstretching the hands, clenching the fist, opposing the thumb and the fingers, squeezing the metacarpals, the prayer sign, the inverted prayer sign. So each of these shows the joint alignment, shows the deformity, exposes the deformities, exposes the restriction, and you can actually pinpoint where the problem is. Thank you. Oh, no, it's very fast. Wait. Okay. And the legs, you have to get the patient on the couch and examine all the major joints in the lower limb, and you look for effusion, and you can again pick out if there is a problem. Okay. And this is for the temporomandibular joint, very commonly involved in polyarticular disease. And open the mouth, put 3 fingers vertically into the mouth, and if you can do that, your TM joint movement is adequate. It's not restricted. The spine, the cervical spine is frequently involved, and children may not complain of the symptoms. So cervical spine extension, lateral flexion, flexion, forward flexion, and you can examine the patient back to front to look for obvious abnormalities, and forward flexion of the lumbar spine. So the PGALS is something you can look at the video on YouTube. You can familiarize yourself with how to do the examination, add it to your daily examination of children. Every child with joint pain does not have JIA. And the first thing is to pick up the difference between arthralgia and arthritis. Okay. And pattern recognition is the other major skill that we pediatric rheumatologists have, rheumatologists in general, actually. So I'll show you a couple of cases. So this is, you can see the pattern. It's a 3-year-old child, 1-day history of acute onset pain and right lower limb limp. He's a well child otherwise. He had a URTI a week ago. His simple blood count and inflammatory markers are not particularly striking. And you do an ultrasound, it shows you an effusion. You can see that there is an effusion here in the joint. And this pattern here, young child, acute onset, otherwise well, single hip, minimal external inflammation. This is called transient synovitis of hip. It's easily managed with a little bit of analgesia for 2 days. Look at this child, however, This is a 3-year-old child. Again, presents to you with a right lower limb, left lower limb limp. But this child is febrile, he's toxic, he's not at all well, he's pseudo-paralytic. He's keeping his joint in the position of rest, flexion, abduction, external rotation. And he will not even let you examine his hip. And you look at his blood tests, he's got very high inflammatory markers. This is septic arthritis. This child is not for a rheumatologist to manage, this is for the orthopedic surgeon to manage. Okay? What about this? Another 3-year-old girl, 2 months history of this child is again, now the story is 2 months. But for the last 2 weeks, the child is totally unable to bear weight. There is mild fullness of the joint, it's very tender to touch. And the way the child sits is like this. Again, pseudo paralysis, both knees in the flexed position of rest. And again, the blood tests are not particularly, worrying or alarming, little bit of anemia. Closer look at that, you can see some perifollicular hemorrhages in the skin. And we take more history here because this child, it is pain, pseudoparalysis without too much of inflammation in the background, does not take any fruits or vegetables. This is a long forgotten condition called scurvy. Vitamin C is an essential vitamin. If you don't take it in your diet, your body doesn't have it, your collagen is poor, and you will develop a lot of problems. Final thing can be fatal bleeding. Okay? But before that stage is a musculoskeletal stage. And all we need to do with this history, with this picture, is do an X-ray, which has some very classical features, the osteopenia, ring epiphysis, and many things. And you can make a diagnosis, treat them with vitamin C, and they will be significantly better. Okay, so again, a very clinical diagnosis. You make it in OPD the day the child comes to you. This is an 8-year-old child. The story is 1 month long. Initially, a right shoulder pain. Then, particularly at night, the child doesn't sleep well. The parents are telling very clearly this child has not been sleeping well for a night, for a whole month. Then there's sternoclavicular joint, then the left ankle, then the wrist. And the child is now unable to bear weight at all, in severe pain. So this is red flags, okay? A child who has lost ability to bear weight, a child who's waking up at night with because of pain in the joint. This is bone pain that's being described, okay? Remember these terms. And the child is in so much pain that the father has carried the child and brought into OPD, okay? And now you look here, there is some anemia. The total count looks okay, but the differential count shows low neutrophils and very high lymphocytes and a platelet count that is low. Already many red flags are going off in my head, okay? And somebody thinking this is rheumatic fever has done an ASO, it's high, but this is not a picture of rheumatic fever. The fever is not significant. This is rheumatic fever does not have nocturnal awakening, does not have counts like that. So this ASO is a red herring. ASO is only the consequence of a streptococcal infection. This child could have also had a streptococcal infection. It's irrelevant in this point. And someone has done ANA, etc. This is not a picture of arthritis. This child has a peripheral smear which is normal. Again, that should not distract you. And now I will show you. Can you play that video? Can you play the video? There is a video. Can you play the video here? This video. So this is a picture I want you to keep in your minds forever. When you see this, you should always alert and have your antenna up. So, you can't play the video? Which one? Not this, the other one, please. The other one. Yeah. Yeah. So I'm trying to examine this child. Is the sound there? Okay. The sound, you can see the child is jerking with pain, and if the sound, you heard that? You heard that? That is not. Can we go back to the PowerPoint? Can we go back to the PowerPoint? Sure. Go back to the PowerPoint, yeah. Go back to the slide. So, no. Right. So this is bone pain. This is a very ominous sign. You have to think of a hematological malignancy here. And this is very important because in children, the commonest hematological malignancy is acute lymphoblastic leukemia. The counts are low. You may not get a normal peripheral smear. The fact that peripheral smear is normal should not put you away from the diagnosis. You should go ahead and do a bone marrow, which we did, which proved the diagnosis. Okay, these children can be missed. They can get steroids, which can mask the disease and can be very, very bad for them in the long term if that happened. 40% of ALL presents with musculoskeletal symptoms, and this is exclusive to pediatrics. Okay, so this is why the definition of juvenile idiopathic arthritis, if you see, is just at least 6 weeks of arthritis characterized by joint swelling, restriction, and tenderness pain. Do you see a blood test anywhere in this? No. You don't need a blood test to say it's JIA. It's a very clinical diagnosis based on your history, clinical examination being to ascertain that there is no other cause for this arthritis. Okay. So the presence or absence of blood tests that are showing various serological tests in arthritis should not be a necessity to make a diagnosis of JIA. So here is now we come to this child, a 4-year-old child who has a right knee swelling since 6 months. And the characteristic symptom here is when she wakes up in the morning, her knee is very, very stiff. She's limping. She's unable to walk. After some time, she's able to walk. This is called early morning stiffness. This is the classic symptom of juvenile idiopathic arthritis or any inflammatory arthritis. Okay? So they don't have pain. Pain is not the major aspect. It is stiffness. Okay? And a lot of workup has been done, which is all not showing much. It really doesn't matter because the symptom is there, the history is there. This is JIA. What is important is the child is now constantly tripping and falling. This is how the child came to us. You can see that she has a huge flexion deformity. It's looking like she's scoliotic, but she's not. It is because of the deformity in her knee that she has an apparent scoliosis, because you make her lie down. You make her lie down and the deformity is that scoliosis is gone, right? So this is long-standing inflammatory joint disease. She's got a long limb now. She's got limb length discrepancy. That limb has grown longer than the other limb. Can you reverse that? Yeah. And she's got a fixed flexion deformity. And more importantly, this kind of arthritis has a second part, an extra-articular part, chronic anterior uveitis, which can blind them. If you don't know that, it is asymptomatic. The children will never tell you that they can't see. It is white eye. It is not a red eye. You have to get the ophthalmologist to examine them. If you don't pick them up, these children go blind. Okay? So this child is a 4-year-old child who came to us, and you can see she has neck extension restriction. You can see she's not able to do the prayer sign fully. If she has to put her wrist straight, her wrist will come apart. Okay, so she's got wrist involvement. She's got a lot of small joint involvement. She's got cervical spine involvement. You can see the swollen wrist with the deformed PIPs in the other picture. That's before, and after treatment, you can see how perfect she's become. This is polyarticular juvenile idiopathic arthritis. When it happens in young children, they are usually rheumatoid factor negative. When it happens in an adolescent like this, they are usually rheumatoid factor positive. And these children, the rheumatoid factor tells us they're going to carry this disease into adulthood. And you have to be careful about that. This child came with a diagnosis of JIA, but what does she have? She has hypermobility. All her joints are showing extreme hypermobility. And if you have hypermobility, what happens is your muscles get strained extra when you do the thing. So you get pain after activity. This girl got pain after dance and karate classes, but she doesn't have arthritis. She doesn't need treatment for arthritis. This is the Baton score. You can check it up in your books. This is a very easy way to determine benign joint hypermobility. Okay, bedside testing. This is a boy, the P-GALS tells you he has a right elbow arthritis. It's after treatment, much better. This boy is showing temporomandibular joint restriction, and the same boy is also showing wrist joint. So this is how useful the P-GALS is. Okay, you do it, you see it. Yeah. And this is another very important thing that most of the time you don't get taught, enthesitis. So entheses are the places where tendons attach to bone. And if there is inflammation of the entheses, and the entheses are seen in the plantar aponeurosis, in the Achilles tendon attachment to the calcaneum, in the iliotibial tract, where the quadriceps attaches around the patella, etc. This is a special type of arthritis which begins with the inflammation of the entheses. And this is the kind of arthritis that goes on to involve the spine and cause ankylosing spondylitis or a bamboo spine in the long term. And in this group of patients, if they are HLA-B27 positive, they are more likely to develop that eventuality. So the previous children with JIA you've seen so far, there is no need to do a HLA-B27. They don't have the picture pattern for that disease at all. These are the patients who have. So this is what enthesitis looks like. You can see how the Achilles tendon is inflamed. And can you play that video? This video? Not this, the other one, this one. The other video, please. Yeah. So this boy is walking. He has a ERA, JIA, and you can see that he's walking with difficulty. When he places his feet down, he does have some pain. He's limping a bit. But more importantly, when I ask him to stand on his heels and on his, so he can't. He can't stand on tiptoes. He can't stand on heels. Okay, stop it. Go back. Yeah, go back to that. He can't stand on his tiptoes or on his heels, and that is enthesitis displaying itself to you. Okay, it's so easy to examine these patients. Yeah. So basically, that's what we do with JIA. We first determine, does the child have arthritis? Is it some other diagnosis? Is there any extra articular manifestation? What subset of arthritis would the child fit into? And then we think of managing them. Okay. So what about these? These patients are very common, very, very common in my OPD. 8-year-old girl, 3 months, progressive right upper limb pain. This is how she keeps her hand, very bizarre position. She won't use it. Someone is feeding her, someone is bathing her. All sorts of things are happening. And she's not going to school. She's not willing to write. And we examine her. Oh, I wish I could. This video, I forgot to record it. So what happens is when you examine her, when you made her walk, and we made her do things, she actually lifted her hand beautifully well. She did everything. So she does not have a actual limitation. This is a functional somatic symptom. You have to go into the social history here, find out what is bothering this child, and what this child needs is mental health support and removing all medications, stop medicalizing the child. Very, very common. We see plenty of these cases too. Now with fever, we see a lot of children with pyrexia of unknown origin. 15% of pyrexia of unknown origin in children is due to rheumatic disease. So this is the one child. Again, I told you, everything is patterns for us. We recognize patterns in patients. So here we have a 13-month-old child who has this pattern of fever. This is called a quotidian fever, very high spikes coming right down, after some time going up again. Okay. And this is going on for 2.5 weeks, not for 2 days, 3 days, 2.5 weeks. There is no focus at all. Lot of tests have been done. Everything is negative. Her inflammatory markers are rising and rising and rising. Every time she has fever, she has a rash like this. And it goes away when the fever goes. This is called an evanescent rash. Okay, so a pattern, quotidian fever, evanescent rash, young child, infection screen negative, but the inflammation is rising. This is called systemic juvenile idiopathic arthritis. Okay, and that's how you make the diagnosis here. This is another pattern. These are 3 different children, same disease, extensive rashes. Look at the child on top, malar rash, crusting everywhere, over the body, hands everywhere. Even the boy has rash everywhere. And you open the mouth, the girl has just some mucositis on her lips, but you open the mouth and you see that asymptomatic hard palate ulcer sitting there. They will not complain of this. You have to shine a torch in their mouth and look for this particular finding. And this, if the child shows you cytopenias on the blood tests, this is SLE. This is where you need to do your ANA test, you need to do serum complements, and you need to proceed. Okay, this is lupus. Dr. House's favorite differential diagnosis, he only got it once, right? We have, in everything in rheumatology, we have criteria for diagnosis. Okay, we don't have to go deep into that, but we have criteria that help us make diagnosis objectively. And this child is an 8-year-old girl, 2 months of low-grade fever, but the main thing is fatigue, reducing activity. She's not able to do the normal things that she could do before. She needs help to rise up from bed. She needs help to sit up. She needs help to sit up from a chair, pull herself up to standing. She's got pain in her joints. She's getting rashes, a malar rash. Her eyelids are pink. That's called a heliotrope hue. She's got these lesions on the PIPs of her joints. These are the Gauthron's papules. So the child is giving you the diagnosis. This is a pattern, this particular kind of rash, these particular kind of symptoms. You just do one thing. You look at the muscle enzymes. All the muscle enzymes will be elevated. A proximal myopathy, inflammatory myositis actually, because the muscle enzymes are all elevated. This is juvenile dermatomyositis. Okay. If you're going to your pediatric clinics, all of you will see these patients. And this is a spotter diagnosis. Very common. It's called Hinox-Schönlein purpura or IgA vasculitis. Presents with this huge amount of palpable purpura all over the lower limb. The great thing about this is you don't have to worry at all looking at the purpura. They give you the diagnosis. Okay, but these children have some other findings too. So look at this. Child has edema of the foot, swelling of the ankle, edema of the hand. So they get vasculitic edema of different peripheries. They get arthritis, which is very painful in the acute stage. They get the same vascular edema in the small of the back. So child will complain of back pain, not willing to rise because of that. Okay. And this is all part of IgA vasculitis. If this child develops abdominal pain, you've got to be careful because they could be getting edema of the bowel wall, and that can be serious and they need proper treatment for that. Okay. And they need to be followed up for quite some time to make sure they are not in that 2% category who's going to get chronic kidney disease with this illness. This illness is it's very common in children. 90% of these patients present before the age of 19. But that 10% who present in adulthood have a totally different kind of disease. So we should not treat children the way we approach adults with IgA vasculitis. We should not treat adults the way we approach children with IgA vasculitis. We need different styles. Another disease you all will see in your pediatric wards for sure is this one. The little child below 5 years of age who comes with high-grade fever, extremely irritable, and a combination of these various clinical features. A non-purulent conjunctivitis, red lips, strawberry tongue, dorsal vasculitic edema, maculopapular rash, unilateral cervical adenopathy, reactivation of the BCG scar, and a few days down the line, periungual peeling of the extremities. And this is Kawasaki disease, a diagnosis that should never be missed because 25% of these children develop coronary aneurysms, which can cause sudden death. Okay, and it can be very beautifully treated, but it's a very important cause of fever in children. If you're less than 1 year of age and you develop Kawasaki disease, you have a 50% chance of developing coronary aneurysms. So even more important. And this is a rare case, but I'm just showing to you because I want to show how exciting my field is. This is a diagnosis I made when the child came into my OPD. Okay. So as a 4-year-old boy, from the second month of life, he's having this kind of rash that you can see below. It comes and goes, it comes and goes, it comes and goes. And he has almost daily fever too. Over time, he's developed this kind of expanded lesion of his right knee. He's not able to bear weight. He's very, very irritable. You look at his head, his forehead is prominent. He looks like he's got hydrocephalus. Okay, we examined his eye, he's got papilledema, not surprising. And so it is a progressive chronic inflammatory condition that started in infancy. That's your pattern here. With this rash, with the papilledema, with the joint problem. Okay, This disease is called NOMID, neonatal onset multisystem inflammatory disease, fatal unless treated otherwise. Fatal at some point, okay? And the papilledema, we confirmed it with genetic testing. This targeted therapy, IL-1 inhibition, interleukin-1 inhibition, we managed to get it for him, started him on treatment. A few months later, he started school. You see the transformation. This is the magic that pediatric rheumatology can create. Okay, so how do we arrive at a diagnosis? History and examination. I would actually fill this entire slide with history and examination. That is the key aspect of our specialty. History and examination, pattern recognition, then we try to form a diagnosis, and then we do investigations keyed towards the diagnosis we are thinking about. So for some patients, it will be autoimmune serology. For some patients, it will be imaging. For some patients, it is biopsies. For some patients, it is genetic testing. Rheumatology is the last bastion of clinical medicine. It's the most satisfying thing to do, actually, today. And what happens if you don't diagnose and treat these patients properly? Severe deformities, okay? Wheelchair bound, blinded by uveitis, receding chin micrognathia, and limb length discrepancies. Lot of, and more. This is just a few things that I showed here. And children, these are 5 children with systemic JIA who came to my care. All of them are 13 years old at this point when this photograph is taken. They've been on daily steroids for more than 10 years. They are like little dolls. They have hypothalamic pituitary axis suppression, both for 2 reasons. One is because of persistent disease that's not controlled, and because of daily exogenous steroid use. And this is fully preventable with good therapy these days. Okay? They will become dwarf adults. So the management will go very briefly. It is a multidisciplinary thing as always. And we have 2 aspects to management. We do general medical therapy. We want to reduce the inflammation first. So we use anti-inflammatory drugs that can be NSAIDs or steroids. Steroids, we would prefer to use intra-articular in children with lesser joints, and use systemic steroid for some period of time to initially bring down the inflammation. But those group of drugs, the immunomodulatory drugs, those are the most important drugs for these patients. The earlier you put them in, the earlier you burn down that disease. And you may need to use some children, conventional drugs which are cheaper, like methotrexate might be enough. All of you will encounter methotrexate in oncology. And in your minds, it is an immunosuppressive drug. For a rheumatologist, so in oncology, they prescribe grams per meter square. In rheumatology, we prescribe milligrams per meter square. There's a huge difference. For us, it is an immunomodulant. For them, it is an immunosuppressive. Okay? So we also have today biologicals, wonderful drugs. They've been around for the last 2 decades or so, and these are targeted, biologically engineered drugs, which are quite expensive, but extremely effective. And they have just turned around the prognosis for these patients in such a huge way. And they are a big boon to our therapies these days. In addition to that, you need to take the family along with the treatment. You need to plan investigations properly. You need to think about making them attend regular school. You need to think about the immunization issues. So many things have to be considered. We'll be finishing very soon. When they get older, at the age of 18, we transition them to adult specialist care, because many of the conditions we treat are chronic and do carry on into adulthood too. And what is the outcome? As I said previously, pediatric rheumatology clinics in the 90s were all wheelchairs all over the place. Deformities were very high. Early joint replacements were very high. Now we have much reduced deformity. These children look just like any other child, going to school just like their peers, just that they have a medicine to take every week. Lupus, the 5-year survival for multisystem lupus used to be only 5% in 1995. Today, it is 95%. That is the transformation. JDM used to have a mortality of at least 30% previously. Today, that is not the case. And what is the future? The future is very, very exciting. And the most important thing, what predicts these good outcomes? Disease duration at the onset of treatment. So the earlier you diagnose, the earlier you start proper treatment, the better for these children in the long run. And what do we have now? The NEJM very recently has brought out CAR T cell therapy for children with treatment refractory autoimmune diseases. Last year, we had the NEJM again coming up with severe combined immunodeficiency, which is a deadly immunodeficiency to get children receiving gene therapy. So this is the future. We deal with a lot of immune-mediated disease, a lot of inborn errors of immunity, and this is the future. And this is where medical students like you should be focusing in your long-term careers. Okay? So as I said previously, we were thinking of symptom relief, then disease modification, then came remission with medications. And today, hopefully, we are launched towards cure. Okay? And I'll stop with thanks to the three institutions that have made me who I am today: JIPMER Pediatrics, QMC Nottingham, and Amrita Kochi. Thank you. Any questions? Any questions? Or? If you have any questions, I'm pleased to take. Thank you.
Thank you so much, Dr. Suma Balan, for such an amazing discussion on autoimmune diseases in children. Such an important study from such an accomplished expert. Now, I would like to call upon stage Dr. Jagdish Vaman to facilitate Dr. Balan with an invite and a gift. Dr. Lataman, could you please come on the stage as well? Thank you.
Dr. Jagdish is here. That is Dr. Jagdish S. He's a past surgery pro. Just say Dr. Jagdish. Jagdish from surgery.
Okay, what do I do?
Thank you.
Lecture. Yes, I request the delegates of this lecture to fill the Google Form projected on the screen. This is to avail attendance for the first guest lecture. Thank you. Yeah. Delegates, please also note that refreshments have been arranged for all of you. Kindly proceed via the exit on the right side of the auditorium. Thank you, please. Thank you.
Hello, check. Hello, mic check. 1, 2, 3. Hello, check. Oh, okay. Okay, okay.
Check, 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 check. ചെക്ക് ചെക്ക് എടാ കേക്കണ്ടോ ചെക്ക് ചെക്ക് ഒന്നുമില്ലല്ലോ ചെക്ക് 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 ഇന്നൊക്കെ
Check, check, check. check one, check two, check three.
Check, check, check. Nice. Good in. Check, 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 check. Don't argue.
Check.
Ah. ആയിഷ എല്ലാം ഒന്ന് മ്യൂട്ട് ചെയ്തടാ.
Um, Tech. I'll start. It was my honor to introduce our next speaker for today, Dr. Vishal Rao. Dr. Rao currently serves as the Chief of Head and Neck Surgical Oncology, as well as a Robotic Surgery Center at HCG Cancer Center, Bangalore. He is widely known for his expertise in complex oncological surgeries and his contributions to improving patient care. Beyond his clinical work, Dr. Rao is an innovator, the inventor of the home voice prosthesis, an affordable speech device that helps restore speech in patients who lose their voice following laryngectomy. This low cost innovation then went on to transform the lives of many throat cancer patients. With over 18 patents on medical devices, surgical techniques, and healthcare innovations, his work reflects a commitment to making healthcare more accessible and effective. In recognition of his contributions, he received the Julie Wilkenfeld Award for International Excellence in Tobacco Control. Ladies and gentlemen, please join me in giving a warm welcome to Dr. Vishal Rao.
Hello. Yeah. Is it okay? Thank you. Very good morning to all of you. At the outset, I would like to thank the organizers of CONNAISSANCE for persisting and ensuring that I come here on time. They've done a lot of arrangements and I'm incredibly grateful. Amrita was there, no? She told me to dress like an intern and come. So I said, I'll follow that. She said, innovations have to break rules. So, I was asked to talk on the topic of innovations. I've kept it a little broad. I've not gone very specific, but I would be happy to take questions and let the delegates come up with their own queries. We have a breakout session after this. And if anybody has ideas or any kind of supports that they need for the ongoing work, we'll be happy to have a one-on-one interaction. So the title that I put for this topic was Possibility to Actuality and How to Make a Possibilitarian. I was talking to Professor Suresh just now a while back, telling about how this whole journey was for all of us, and I'm seeing the future of a lot of the new age India that's coming up, and I'm sure you will be thrust with more responsibility than we are. So I'm going to go forward with talking about a little on the subject. This is my cancer center. We have about 24 cancer centers across the world, and we focus only on oncology primarily, and I head the group. We also have a small vertical of fertility. We have a vertical of genomics and bioinformatics and laboratories. And today, I think I'm going to take you through this whole journey of making you think. And the first stereotype that I broke was my wardrobe, just to help you make you think. And then I wanted you all to think further. So we run these programs on design health thinking. Okay. And the fundamental thing is, how do you find a problem? How do you get rid of the problem? And in the process, how do you take possibility to actuality? And that's how I see all the possibilitarians in this room. And believe me, this journey from possibility to actuality is a very beautiful journey. Not everybody makes it, but those who make it understand that it's a lifetime sometimes that is spent in this whole story between these two words. I'm going back to COVID. I'm just going back to COVID because all of us here in some way experience COVID, correct? 0.85 attograms was the weight of the virus. So roughly about 5 grams of the virus stopped the world. And that's how I start to look at the way things change for healthcare in India and globe. 5 grams of this virus was all that was required to stop the world. Now, why am I talking about World War C? C, by the way, is for COVID and not China, just for your disclaimers. Winston Churchill said something very beautiful about Russia at that time. He said it's a riddle wrapped in a mystery within an enigma, but perhaps there is a key. My friends, even today, we don't have the code and the answer for this whole thing that happened in the last 3 years, from 2020 till 2022. COVID became a mystery, even today, fully not solved. Yet, I think these words seem to be emphatic and relevant. And I'll divide the life of life post-COVID into AD and BC. AD is after disease and BC is before COVID. You see, before COVID was a different era, and after disease will be a different era. And that's what we are experiencing now. And why do I say that? Look at how the world changed post-COVID. Look at how innovations happened. We used to fight wars with soldiers, we fought it with doctors. We used to fight war with weapons, we fought it with soaps and sanitizers. We used to fight it in close encounters, we fought it in social distancing. And most important of all, the first sense of the COVID was loss of sense of smell, but actually it was loss of common sense. Think of what you did in wave one. How many of you all know of all those interesting stuff you did in wave one? So the perspective of this world changed with COVID, the way the world looked at it. But something very interesting happened along the way, and the most important thing that I would like to tell you all is, before COVID, it was infrastructure and defense that were at the top. Many of the times when you ask top leaders of the world, the last UN meeting when we were discussing on something like this, what was interesting was many of them who pondered on what was it that happened that changed the world and looked at eliminating COVID. We won the war on COVID. We are alive here in this room. The most thought-provoking part of it is, it was not that talent and technology came together. It was just that maybe the 20 powerful people of this world were at threat and they wanted to save themselves, and they decided then we will save the world. I'm telling this with a fair amount of confidence, because if you were to take all the millennium goals today and we were to work on it, and if it would be a global problem, we would be solving each one of those millennium sustainable development goals, SDGs, today. If each one of these global powers took up one topic and we would decide to eliminate them, like the way we did with COVID. So I'm going to play this video. Can we have some volume? Is there a volume? You can watch the lines of it.
To help you get a good degree. We never had this opportunity.
I'm just going to play this again for the sake of...
Right now, there is a kid finishing parents' evening in a heated discussion with his mother, saying, why does he have to study subjects he will never ever use in his life? And she will look at him blank-eyed, stifle a sigh, think for a second, and then lie. She'll say something along the lines of, to get a good job, you need a good degree. And these subjects will help you get a good degree. We never had this opportunity when I was younger. And he will reply, but you were young a long time ago. What you mean? And she won't respond, although what he implies makes perfect sense, that society's needs would have changed since she was 16. But she will ignore him, grip his hand more sternly, then drag him to the car. But what she doesn't know is that she didn't ignore him just to shut him up. She didn't lie because they were just returning from parents' evening and an argument in the hallway would look bad on her resume. She won't lie because she just spent the last 1 hour convincing a stern-faced teacher that she will ensure that her child studies more at home. No, she will lie simply because she does not know any better herself. Although her whole adult life, she has never used or applied Pythagoras' theorem, prophetic fallacy, and still does not know the value of X. She will rely on society to tell her that her child, who has one of the sharpest minds in the school, is hyperactive, unfocused, easily distracted, and wayward. Students, how many equations, subjects, and dates did you memorize just before an exam, never to use again? How many A grades did you get, which were never asked for when you applied for a job? How many times have you remembered something 5 minutes just after the teacher said stop writing? only to receive your results 1 month later to realize that you are only 1 mark short of the top grade. Does that mean remembering 5 minutes earlier would have made you more qualified for a particular job? Well, on the application form, it would have. We all have different abilities, thought processes, experiences, and genes. So why is a class full of individuals tested by the same means? So does that mean Sherelle thinks she's dumb because she couldn't do a couple of sums? And if this issue is not addressed properly, it then becomes a self-fulfilling prophecy. Then every school has the audacity to have a policy on equality. The irony. Exams are society's methods of telling you what you're worth, but you can't let society tell you what you are, because it's the same society that tells you that abortion is wrong, but then looks down on teenage parents. The same society that sells products to promote natural hair, looks, and smooth complexion, with the model on the box half photoshopped.
Okay, I don't know. It stopped in between. Maybe we'll play it some other time. I'm not sure if there's any error. But somebody can watch this video. It's a very nice video that talks about breaking the stereotype of thinking and trying to question the status quo that the world is going through. So post-COVID, what happened was Boston Consulting Group came up with one of the very interesting reports, which is called Transforming Beyond the Crisis with the Head, Heart and Hands. And Boston Consulting Group is one of the world's most famous auditing groups, and they came out with something very thought-provoking, and they said a people-centric transformation agenda will be a key differentiator post-COVID. As we see today, you see health, infrastructure and defense come on the same platform. They're all coming together to talk on the same platform. And believe me, my friends, health never enjoyed this space before. Suresh sir is here, some of our seniors are here. We've seen the struggle that health had to go through to actually get a seat on the table in the top political issues. Today, health is a priority, and I think you all are sitting in a time when I think you cannot better explore and exploit the situation for benefiting humanity and society even better. So, we are in an era which is opening up to completely a new way of thinking. It's more of conscious capitalism rather than venture capitalism. It's creating wealth with value, and it's creating ambition with purpose. So we are definitely in an era where this generation of students can make so much out of what you have, because you have information in your hand, you have power in your hands. Now, how are you going to utilize it? How are you going to reshape your future is something that's going to be interesting for you all to look at. So now today, with infra, defense and health coming together, how would we reimagine this world? And that's something for you all to think about now, not 10 years from now. And I think that's something that I want you all to look at. Now, this is a very, very classic paper that came out in the Lancet some time back, looked at translational research bench to bedside model. Now, if you look at this conventional story, it takes about 17 years from bench to bedside for something to come out into the market. And that's why nobody is interested in healthcare, because it takes such a long time to invent, pursue it, and then after that, bring it up to the market or to the people. Now, what happened was COVID created what we call as a research practice hyperloop. Something happened during COVID that the world realized that the way they were doing research was wrong, and we had to relook at the whole thing in a new way. So if you look at the same thing, now changed from 17 years to 17 days, some of them 17 hours. Regulatory changed, pathways changed, the approach to clinical medicines changed, and it was transformative. Now the question is, how am I going to use this in my journey? What am I going to do with this? And what difference can I make in my personal journey in this? And I'm going to share 3 lessons quickly in this time allotted to me. And these are lessons that I learned through my journey. And I'm just going to ask you all, what's most interesting about the journey of life, the lessons that you learn from the journey of life? How is it different from the journeys that you learn in these classrooms? Can somebody take a guess? How is it different? Experience, correct? Anything else? Think about it. Long lasting. Okay. Anybody else? Anybody knows how to shout on the top floor there? Sorry? Practical. Practical, correct? Yeah. So the most interesting lessons in this particular journey are, the journeys, the lessons that you learn in your classroom, you get the lessons first and the exam later. Whereas the lessons that you get in life, you get the exam first and then you learn the lesson. That's why you don't forget them. That's why they're experiential. That's why they're practical. That's why you can't forget them. So I'm going to share with you 3 such lessons that where the exam came first. Then I learned some lessons. And that's how innovation happens. Innovation happens the reverse way. It doesn't happen with you going, reading your book and then doing some innovation. Innovation happens in the most unplanned time, in the most unknown places. And that's where you see the seed of innovation laid. So I think for all you guys, and I believe I've been called here to JIPMER to address connaissance. Connaissance is what? Nothing but a French word for knowledge, correct? And if you go back into the philosophy of knowledge, I'm not talking philosophy here, but I'm just telling you should know that even knowledge has a philosophy. There is a way to acquire knowledge. And I'm seeing that rapidly change today. The methods of knowledge that I used for learning a few years back today are not relevant. I was talking to a venture capital team, friends of mine, whom I sit in the board of. And they were talking to me about attentionless learning. They were talking to me about mindless learning. They were talking to me about rapid learning and micro learnings. I was looking at the entire behavioral change pattern of learning itself as methods of knowledge. If you look at an Insta 7-second reel today and look at learning, it's completely changed the way education and knowledge is being transferred across, correct? WhatsApp University, Instagram universities are all bigger universities today compared to all the universities put together that we are running. And interestingly, the methods of knowledge are changing. And knowledge, the way you acquire today, is also being in a flux. So I believe this is your responsibility, and that's something that I'm putting forward to you, that maybe 10 years from now, when you look at it and remember that somebody like this came here and stood here and spoke, this possibilitarian job is not just to do what's immediately at hand and what's right now. Like I was talking to the gang that was sitting with me in the lounge, and I was talking to them on what are you all thinking about in your first year, second year? How are you looking at these subjects as subjects of the future? So I think that's something that for you is important as a responsibility. Now, I started my slide by saying that, it's very simple, correct? A possibilitarian's journey is possibility to actuality, and that means find a problem, get rid of the problem, correct? And I want to just focus for a minute on how do you find this problem? And that's the most beautiful part. Remember, you may have to spend your lifetime trying to solve a problem or find a problem. And it's not easy to find a problem. It's not at all easy to find a problem. You may have to spend. I remember one of those days in US in the research labs. I used to meet a friend whom I met on the first day of acquaintance, and I was talking to him, and we shook hands. And what is the first thing you asked? So what do you do? And he said nothing. And a couple of days later, I asked him again, so what are you doing now? He said, still nothing. And I was like asking him, so how long has this been going on? He said, 3 years. I said, 3 years, nothing. He said, yes. He said, not able to find a problem. He said, very difficult. So today, well, he's in Italy today, and while we still connect, and I tell him, I said, that was one of the most beautiful lessons for me, that it took you 3 years plus to find the right problem. And that right problem took you to a certain place in the world, which today has made your work relevant. But the point was to find the right problem. So this is a very interesting problem statement that came up. So a Dubai head of marketing for Ola was faced with the problem of coming up with a disruptive plan for marketing. So, he was sitting with his friend in a pub in Dubai, and he was telling that, look, I have to come up with this disruptive plan with which every Arab is holding a cola in his hand in the next 1 month. So he used some very interesting AI algorithms to come up with a marketing plan. And the algorithm suggested to him to cut the language barrier. It said, just go on pictorials, and that's the way we cut the language barrier. And you'll be able to reach millions of Arabs faster. So he came up with this brilliant marketing plan. A man lying dead tired in the desert drinks a cola and starts to run. Simple. Cut to chase, he says, disruptive marketing plan. Now, a few days went by, both of them again met. When he met him again, this man looked depressed, little low, dull. So he asked him, so I thought By now you must be promoted as the CEO of the company with the way you have disrupted this whole market. He said, no, things didn't go as per my plan. There were some small problems that happened. There were glitches because of which things went wrong. He said, what was it? He says, I forgot to incorporate into the AI algorithm that the Arabs read from right to left. So now you look at this whole thing and look at the programming of what went wrong in that. So he lost his job because the whole plan went wrong because there was something. And this is the foundation of what I call today as I was sometime back talking at the Karnataka Legislative Assembly on a discussion, and I said that the fight between artificial intelligence and natural stupidity is a big one. So natural stupidity cannot be replaced by artificial intelligence, and do not expect to do that. So somewhere when we talk about every of these problems today and somebody tells you, AI solve kar dega usko. AI सब कुछ solve नहीं कर सकता. Natural stupidity is not a replacement there. So finding a problem is very relevant. And I'm talking about some time back, I spent some good time with Cambridge. They have a very nice program called the BioSpark program. They had the Newton's tree there, and I was telling that look at the Newton and look at when Newton saw the apple, he saw the laws of gravity. But when Steve Jobs saw the apple, he gave me a Mac computer that is not compatible with any system. Amrita has been tense from morning on how am I going to fit that system into this now. And that's the reality of the way you look at a problem, correct? The way you look at a problem can be different. Each one of you here can look at a problem in a different way, embrace it in a different way, and interpret it in a different way, solve it in a different way. So always remember this, that it's not about just the problem, it's about the way you look at the problem and the perspective you bring with it. And the third principle that I believe is that an answer appears when the question is ready. Most of the questions that we have are half-baked. As I gave you the example of that friend of mine who was spending 3 years to find the right question. It's not easy to find a good question. So I understand that we are given theses, research projects, short-term projects. Next time, try this out. Take a genuine problem and work on it and see how difficult it is. I must share an experience with you all on Stanford. Last year, I was at the Stanford India Dialogues, and I was with their global dean, and we had to address a small group of youngsters who were interning at Stanford. And they told me this is a breakout session, so let's sit down and talk. And after a small interaction with them, one of the gentlemen, one youngster stood up and told me, Dr. Rao, all that is fine. You know what? There are so many street people in California over here. It has the largest number of people living on the streets in US. We're trying to do something with it, but there's not much of funds here. We're paying our fees through our nose. We've got no much of stipend, but we really want to do something for these kids. So they told me, what is your solution for that? I was taken aback. I said, I was not ready for that, correct? I just came to give gyan, free gyan. And I said, what is this? I mean, this is a practical problem they've given me now. What to do right now? And that's what the current generations would want to know, correct? What do I do right now? So I looked at him and I looked at the dean and I said, what should I answer for this? I said, I don't know what to do for it right now. But just then it struck me, in my pocket was $1,000, which they had given me as an upgrade to my business class. So I took out that money and I gave it to him and I said, look, I'm funding this project. Small fund, $1,000. I'm saying, take this. And now I said, I'll stretch my legs a little bit less and I'll go. But I want you all to use this money and start the project. Now, because I had already given my first token of donation for that project, because I had nothing else to tell him, but I said, let me start it with my funds. I'm not going to wait for anybody else. So I gave what was there, which he had given me about 10 minutes back. Because of that, there was somebody from Apple. He said, it's such an insult if we don't participate in this. So he gave another equal matching amount. Facebook was there, so they gave another matching amount. So these guys collected some good amount of money and they started a small project that day and started to implement it for the old people on the street, the people living on the street. The point I'm trying to make here is that the day your question is complete, your answer will come. And he was very clear about what he wanted. And that day when he stood in front of me, I think my pocket had to get empty. But I told him, I said, I'm going to bend my legs, so should you. And you should work hard on this and solve it and show me next time. And I told the global dean, next time don't surprise me with these kind of questions, But the most beautiful part of these things is if you refine your question well, you will be able to find the answers coming out much easier. Most of us come with half-baked questions. You don't research well on your questions. So my exam first, somebody like this in an audience when I was talking to the first year medical student asked me, sir, how do I get a brilliant idea? I said, if you hold on to one idea, one problem of a patient all through his life, you'll be flooded with brilliant ideas. You don't need 200 patients for it. One patient's problem, hold on to it, hold on tight to it, and you'll be able to realize that you'll be flooded with ideas. So the question is, sometimes we go the reverse way, and I'm seeing that in Bengaluru. Bengaluru is the IT hub, you see. Everyone is IT, and it's cool. And you feel jealous of them, because they are leading the best of lives. I was telling them when COVID was happening, they were saying, we're tired of working from home, and there used to be complaints to our chief minister. We're tired of working from home. And so as a doctor, I wrote a small note to CM saying that, so we are trying to reach home here. So can you please have a conversation between both of us sometime, the IT people I'm jealous about. So a lot of comfort, a lot of things. And Bengaluru is a hub for a lot of innovations. So I was talking to them and saying, if you hold on to one patient's problem rather than 100, you'll be flooded with brilliant ideas. So I had a problem. I used to see these throat cancer patients who couldn't speak. And fundamentally, once they lose their voice box, they lose their ability to speak. Now this comes under the Disabilities Act now. And I looked at it from a simple perspective of a security guard who told me when I operated on him. He said, I've lost my voice, I've lost my job. Now tell me, what do I do? That was the initiating thing for me to see on what could I do for making a difference. And there were two machines. There are two patents in this world at that time. One from US, Dr. Blom's, and another one is from a company in Europe. There were two patents in the world, and I wanted to look at what can I do for this. These were 45,000 rupees to 1.5 lakhs. Every 6 months has to be changed. So can you have the volume on this, please? So I invented the third one in the world. And when I did that, I remember in 2015, everybody told me this is not going to work. Globally, this is not required. This is not relevant, blah, blah, blah. This is not going to be able to take it to the world. I got the world's third patent. So I'm standing here in front of you as the third person from the world. One from US, one from Europe, third from India. I'm sharing this video to tell you all that there's no difference between me and you. I'm telling you, I'm just one more failure, but just thought of keep trying, and just make this. And this was gifted to me by Bill and Melinda Gates Foundation and the BBC as a small token of appreciation for the work we did. So I'm going to quickly play a short video on this, if it works. Is it working? %% of patients come to us in an advanced stage where it's difficult to preserve the voice box, and 80% of them come from the rural area and poor backgrounds. Majority of our healthcare is private and cost prohibitive. That was the reason that I felt that there was a dire need to actually help these patients speak again, because speech is a right and not a privilege. Throat cancer patients, especially in stage 4, end up losing their voice box to throat cancer, because by that time the voice box is completely destroyed. Now in this set of patients, they can speak again if the windpipe is connected to the food pipe and the air supply from the lungs are able to vibrate the food pipe so that the patient can speak again. Now it is here that the brain trains the food pipe to vibrate again and help the patient speak. Introduce myself.
This is a simple device. It allows patients to phonate or to make voice again and be back to leading a full life, and oftentimes it is the only ticket they have to getting back to employment and to having fulfilling and economically sufficient life.
This was a simple innovation that was done and that has touched many lives in a very simple way. Now, believe me, when I started this journey, I did not think that we're going to reach here. But I'm seeing step by step, I did one voice box, and I remember my co-inventor, Shashank, was there. He's a silicon expert. So we both partnered and did this. At that time, I wanted to give one voice to one security guard. That's all. That was my intent, so that he gets his job back. By the end of this entire thing, I realized that we needed 500, then 5,000, then 5 lakh. So the government of India reached out to me and said, yeah, the silicon is a complex subject, so why don't you take it up? And so today I have India's best silicon manufacturing factory for healthcare units, for healthcare inventions, for healthcare innovations, for which US, Germany, Russia, all of them are coming forward, because now this kind of a setup which is there in Bangalore is not available anywhere in India. You have to go to China to do this, and that I have built in Bangalore because I had to then solve. So then I invented a tracheostomy tube, I invented certain hygroscopic Ryle's tubes, I invented certain other devices. And what happened after that? I got a call from Dr. Blom from USA, the first inventor, and he called me up and said, Vishal, I have some dreams. I don't think I'll be able to fulfill it in USA in this time. Why don't I send it to you and you fulfill it here in India? So I'm saying this is the era of collaboration, not competition. Look at how the world is changing. Now somebody would have said the other competitor from USA will try to buy this fellow out or try this, and this patent was valued at some few, whatever number of crores, correct? Now I would have taken it, sold it, and I would have said, let me chill my life like an IT guy and say that I'll sell that company into it. But what I wanted it to be taken to the rest of the world. So as of now, with the support of Government of India, we have been asked to take it to 144 countries. And that's what we are doing right now. And it's a Herculean task. It's not going to be easy. I may take the next 10 years doing this, but I am determined to achieve this. What I'm trying to tell you all is, if you stick to your wicket and you stick and play to it, you will be able to achieve some of these goals. So today we have thousands of patients speaking with this. Last month, the Prime Minister's office released a Netflix series on this. And in that particular Netflix series, this was a series and a documentary made for us. And in this, 8 of us were chosen. One of them was me in healthcare. And this, I never thought in my life I'll be in Netflix. And I did come on Netflix. This is last 1 month back, and the PM's office released the life of 8 people who made a difference by trying to work on things that were not possible. The point I'm making here is, today I have thousands of patients speaking with this who have not spoken for 10 years, 14 years, 18 years, who are again speaking with this, and I've disrupted the whole ecosystem there and created an ecosystem for others to invent also. Because what else will another person do if he has a silicon problem? He can't make a factory out of it. But today I have various companies coming to solve their problems, various startups coming to solve their problems. So I have 3D printers, I have state-of-the-art LSD molders, to extruders, to all of the state-of-the-art devices to make a device for maternal and child care, to baby feeding bottles, to everything, whatever health grade which US and Europe needs. The point I'm again making in this journey is not about accolades, not about rewards, awards, all of this. That's immaterial. Look at the impact that we did on lives. When you focus on that alone, rest can happen around it. Don't focus on Netflix, don't focus on BBC and all that. It may happen. I'm saying that I never went to Harvard or Stanford, but today I teach there. Today I teach at Harvard, at Stanford, at Hopkins. I teach at all these places on disruptions, and I don't have a degree. I don't have a degree for all of this. But it's simply solving one patient's problem that led me there. And today that's what I'm seeing and trying to make a difference. And today I'm happy to announce and tell you all, with Netflix, we collaborated with Shankar Mahadevan to actually make a cancer patient sing. This is the first time we disrupted it to that extent, because Netflix asked me, what else would you want to do? And I said, I would like to make them sing. I think they've not been given empowerment enough to sing. So we got the copyright for Mile Sur Mera Tumhara song, which is that old song that was given, and the copyrights were handed over to me, and I made my patient sing Mile Sur Mera Tumhara with Shankar Mahadevan's team, and now we've got more people coming on board from Bollywood to join hands and help us do this. So we now run this initiative called Gift a Voice, where we're helping people gift voices and making the world a better place across the globe. So I've been to Tehran. I was there some time back in Tehran, helping some of the patients over there who have not had voice. Somalia, Syria, all the complex places. Tell me the place that where there's no access, we've gone there to try and see if we can make a difference. So, it became a case study in Harvard to look at this entire thing. So today I go and teach at Harvard on disruptions. And in one of those talks that I was sitting and doing, I was having the Rolls-Royce CEO sit with me. And he told me, he said, Vishal, I want to keep a small part, your voice box in the Derby Museum in Rolls-Royce. And he offered me a job also. He said, why don't you come and work with us? And I told him, I love to go. I've always dreamt of a Rolls-Royce. I said, I think this is my dream come true. So he didn't give me a Rolls-Royce, he gave me a job. He told me come and advise us. So I was advising Rolls-Royce on non-domain disruptions. So he said the core idea of a non-domain guy disrupting a domain area. Because today what has happened with education is, if I'm engineer and mechanical engineer, then I'll do the same AutoCAD drawing the same way because I've been taught the same way. So for some reason, knowledge has become a barrier today. And I think that's the thing that we need to break. So Honorable Prime Minister took this to Davos. We were actually, we presented our work at Davos in the World Economic Forum. And that brings me to the lesson number one. Simple lesson, but I realized that what I want to tell you is, with all of this long story of all these exams, I think we are not constrained by the discipline of rigor. We all work very hard, but by the limits of our purpose to make a difference. And I think that's defined by your imagination. How much can you imagine to break the boundaries of making a difference and a change to this world is the question you have to ask yourself. And just keep a tab on time and tell me if I'm running out of time, I'll cut short of it. This journey from ambition to purpose. See, we all have ambitions here, correct? I want to be director, then I want to be whatever, chairman, and then something else. All of us come with some desires. And the path to the purpose, I think, is a very powerful path. When your ambition meets your purpose is when you have a fission reaction inside you, and that's when it gives more power to you. I was congratulating the team of CONNAISSANCE over here today. See, I was not supposed to come for this event, and this lady didn't allow. She gave me some 40 calls, and she said, no, he has to come. And I kept telling her every time an excuse to say, what, bad scene, boss, I can't come, there's no way. She said, I'm going to make you come wake up at 4 o'clock in the morning and then drive down and you come here and then you take your flight after that next one to Chennai and be out of it. She made one crazy itinerary for me, because of which I'm sleepy on the stage. I'm forgetting a couple of things, but she ensured that I'm on the stage over here today. So kudos to Amrita for that, for persisting. I'm just telling you the power of persistence. I'm saying she didn't give up. I think the dean called me up, their office called me up, everybody called me up, but this one did not allow. She said, you have to come here, arrive and be here at this time. Close your eyes, come here and just do the presentation, but be here. But my point is to persist and work towards a goal and achieve it. And I was telling, I've only come here because of persistence, not for anything else, because I really don't know this whole meeting, conference, all of that I don't know. I know that there's one person who was persisting to say that I should come and be here. So I am here. So, I always believe the end of education should be knowledge, and the end of that knowledge should be some form of use. I'm sure the next speaker, Suresh sir, is another example of what this whole story will be about. And if you can't serve the person next to you with all your knowledge, what's the point having all of that great knowledge for yourself, So I'm a biker. I love bikes. I just go biking a lot of the times to take a break. And I must share a very quick story with you all. So I have a senior colleague of mine, Dr. Swaminath. He's a philosopher come guide mentor to me, very senior gentleman. But we both talk philosophy. He's a psychiatrist. So he kept telling me he's running a small initiative towards Mysore somewhere in a forest, which he always tells me you should come and visit. Now I'm a busy man, and then I take a break, and so that was the day we were a group of bikers going on the freedom run, and I was biking. And for those interested in bikes, this is the intruder. So I was on the intruder on this race, and I thought I'll take a break and meet Swaminath and go and say hi to him. He's running some initiative for so many years. He's been telling me I've never had time. So I thought I'll take a detour. So I went here, and this was the center he runs. It's called Chittadama. That's Dr. Swaminath, my friend and critic. So Dr. Swaminath told me, finally you have arrived, after so long. It took you so long to come over here. I said, sir, the reason was biking. So on the way, so I stopped by. I thought I'll say hi to you. Now, Dr. Swaminath, you know what he does over here? He believed in a problem. He believed that tribal regions have psychiatric issues which are very complex. I don't think so, but anyways, he believed in it, and he spent his times in tribals searching for people who are wanderers, whom you and me may see in the roads of Pondicherry here and say that they are mad or drunk people, and we'll ignore them and walk out. Dr. Swaminath would take them to the center, help them remember who they are, and that would be a few years that he would spend with them, and then after that send them back home and help them live a life. That's what he did through his life. So when I went there, I was kind of quite shaken, and it was a beautiful experience. These are some of the people I met. He came like this. When I met him, he was like this. This gentleman came like this. When I met him, he was taking care of the farm and the kitchen. I ate over there. I was actually very moved by what he had done. I mean, something phenomenal. I forgot my bike. I forgot everything, and I just sat there for hours, spending time with all of them, trying to understand. Anyway, that was a long story short, but towards the end, Dr. Swaminath asked me, he said, Vishal, in my diary, I want you to write something about how you felt. And I said, surely. I said, I will. And as I was writing, I was filled with emotions, and I told Dr. Swaminath, I said, I want to tell you something. Can I give you a suggestion? So Dr. Swaminath is a very curt and very blunt individual. So he's very sarcastic also. So first thing he told me was, before you open your mouth, I want to tell you something. If you open your mouth and give me a suggestion, you only have to implement it. He said, do not open your mouth otherwise. So I got a little taken aback. So I just kept my mouth shut for a second, and I said, should I open my mouth or not? Because I was about to give him some visionary suggestion. Then I said, ab to mujhe karna padega isko. So retract. Then a couple of seconds later, mustered 2 breaths, and I told him, I said, look, I was thinking if there was music, these patients would it will be making it much better for these patients. So I was thinking, why not keep music here? He's like, brilliant idea, Vishal. Please go get it and keep it over here. So I was now taken aback, wondering what to do. How do I figure this out? How do I go but I went back to Bangalore, cool. Bangalore IT City, called up the E-Zone was there at that time. I called the CEO. I told him, boss, I need a music system speaker. I want you to look at it. He sent me photographs on WhatsApp. I cleared it. Told him I'm going to do the payment online. Got it, ordered it, he couriered it, it went there. Why I'm telling the story is, once the music system reached there, I thought Swaminath will call me up and thank me. Correct? No, he called me up and blasted me. He told me, he said, useless fellow. He said, who told you to send all this? I said, sir, itna badhiya system hai. I said, what are you telling me? He said, bhai, these are psychiatric patients. They are not people who are going to be here in your party or in some get together who are going to listen to music. I want wireless speakers, which can be wall mounted. I want a carpenter. I want all of this so that they can be mounted, preferably remotes, so that we can take care of it. Caretakers can play that music. You are given me some system. This is just run of the mill. He says, you didn't think of the problem. I said, sorry. I said, I didn't realize it's so complex. He said, you should have asked me before buying it. I said, you didn't tell me. So we kept arguing on this, He said, take it back now. He said, so I took it back. Now I'm doing research on my own. I'm going to JC Road, figuring it out, going to some showrooms and saying, I want specifications, correct? But what I'm telling you, my learning from this was something very beautiful, and I'm going to share that. This is what Swaminath told me. Advice is the greatest vice. We all give advices to everybody. अरे वो ऐसा करना चाहिए, वो ऐसा करना चाहिए. So I now follow the same philosophy in my silicon factory. When somebody comes and says, no विशाल ना एक और फ्लोर बना के वहां पे इलेक्ट्रॉनिक्स करो, ऐसे सर आप बिल्ड कर दो उसको ऐसे. अभी मेरा तो 15 साल चला गया इसको बनाते बनाते. And this is a very good rule Swaminath told me, and I keep thanking him every time I meet him. I said, sir, वो बढ़िया था sir. The worst wise a man can have is advice. So I remember one thing, you do not have an idea about the efforts people take to build something. Sometimes it's a lifetime of work that people do. So how do I find my purpose in life? And so I'm again telling you all something very interesting, that you connect the dots when you look back. Connect the dots when you look back. And I don't know how many of you all here have read the book by Randy Pausch called The Last Lecture. If interested, please either YouTube may watch that video or read his book. Brilliant, okay? So I was there in Pittsburgh on the day he died. So me and my senior colleague went to attend his funeral at Carnegie Mellon. I got a gift of that book on that day, and I read that book. It's one of the most finest books I would have read. He was dying of pancreatic cancer, and he wrote about living his childhood dreams. It's called The Last Lecture. So in Carnegie Mellon, there was a culture that once you're dying, you give a last lecture. And this gentleman was giving the last lecture because he was dying. But typically when you retire, you give a last lecture, I'm sorry. And he was dying of cancer, so he was asked to give the last lecture. So I'm going to close with a couple of points very quickly. Last year, when I was working with IFIA and this, they put me as the personality of the month, and I was talking to them on inventions and telling where is India today. And looking at this, if you look at China, if you look at USA, India is over here, and this bubble is here right now inside this hall. And what I want to tell all of you is, if you want to make this bubble move forward, and this is the number of R&D expenditure to the number of people. Remember Vikshit Bharat, all of this is good here, but this Vikshit Bharat is out here, inside here. So if this bubble has to move upwards, and we are here, my friends, this is our reality. So no matter what we talk and try and boast, this is our reality. That's where China is, that's where USA is. So I think the expenditure has to increase, the number of people has to be more, and we have to make it more productive. We have the potential and the capabilities to do so. So I think for students here, I would like to sum it up and tell you that look at this and say, when you choose your career, somewhere early in life, you need to start looking at it on, do I want to do research? Do I want to do invention? Do I want to do innovation? Or do I just want to do jugaad and live life? But I think these are the four options you'll be coming up with. Sometimes you'll have to have a combination of one or two of these. And I'm just giving a reference to one of these very interesting articles that came up in BMJ. I don't know how many of you have read this article, a very interesting article. Parachute used to prevent death and major trauma when jumping from an aircraft, a randomized control trial. Very interesting study, and the study's conclusion was parachute use did not reduce death or major traumatic injury when jumping from an aircraft in the first ever randomized evaluation of this intervention. However, the trial was only able to enroll participants on a small stationary aircraft on ground, suggesting cautious explorations on high altitude jumps. So I'm saying sometimes in the search of evidence and in the era of randomized control trials, we are going on doing RCTs, and sometimes looking at the obvious, we have forgotten. So I would again urge all of you all to say, yes, evidence important, all of this important, but we are living in a post-COVID era today, and great opportunities lie for us. I'm going to skip through this, sorry. And I'm moving to tell you that, from Make in India, we've presented this to the Honorable PM and the office, saying that we need to move to Create in India now. And that's what I did. I did not want to take anything from anybody. I wanted to do everything here. That's Create in India. Make in India is like you import from China, assemble in India. A lot of people were doing that. And I said that the version 2.0 of Make in India should be just Create in India. And this is the logo we designed and gave it to the government of India to take it as an initiative for our side. And we run these programs on design health thinking, where we actually use domain, non-domain disruptions. And based on that, we've invented a lot of things. I'm not going to go into the depths of all of this, but we've invented some drugs. These are patent granted drugs. We've developed some cancer vaccines, which we are now in phase 2 clinical. Phase 1 we've completed. We are entering into phase 2. This is another tracheostomy tube which I invented because a villager from Chikmagalur died because there was no suction in the PHC. So we invented a super hygraphobic tracheostomy tube that does not get blocked. We invented some robotic instruments. We've invented some other drugs which we've now categorized under allopolyherbals, not the Ayurveda route, but with the data allopolyherbals, because 75% of the drugs that we get today have some plant extracts. And it's great to, India is a biodiversity hub and we've only exploited 4% till now. We've partnered with Microsoft and we've invented something on extended reality that we're working on. And this is some of our work showrooms in Bangalore where we actually help encourage youngsters to come and invent. So we have these ecosystems that are there today to come help invent. I'm the chairman of the Possible Group for Health, which is a joint initiative with the government to actually come and look at disruptions, health innovations, joint collaborations between countries. Lastly, I think some interesting dialogues with Dalai Lama when I had. He told me something very beautiful. He said, an idea comes to you, not from you. He said, an idea comes to you, not from you. So hundreds of people here are getting the idea at the same time. The question is, who utilizes the idea better? And we think the idea came from us, correct? How many of you here wake up every morning to this brilliant idea to just realize that somebody has already done it? I wake up every morning to some Nobel Prize winning ideas and I think 200 people have already finished it. I feel very bored and then I sit and sip my coffee and go back to work. So just closing it, I just want to tell you all that we are in an era where if opportunity wants to knock, you have to create a door. I mean, there's nothing called opening the door now. Create your own doors, build your own doors on this and make a difference to what you're doing in your own fields. I've come here to just share some messages. Justice M.N. Venkatachalaya, the former Chief Justice of India, told me something very beautiful when I gave the voice box. He said India's outlook on freedom should be looked at as not merely expansion of our works and deeds, but expansion of our freedom to make a difference. And when I gave him the voice box, he said, remember, the GDP of this country can be run by pirates and smugglers better than politicians. If you give it in their hands, they'll run GDP better than this. So the country's progress cannot be assessed only on GDP alone. He told me a very beautiful example. If 3 doctors every day drive from the hospital to the home to the hospital, the GDP is good. If the same 3 doctors take a Mercedes and drive it, it is even more better. And if the same 3 doctors on the way to the hospital die in an accident, GDP is the best. So GDP is a limited way of assessing progress of a country. The progress of a country or a nation need not just be looked at by GDP alone. So, and I want to leave you all with these thoughts on Ikigai, which is the Japanese way of looking at it. It's what you love and what the world needs is your mission. What the world needs and what you get paid for is your vocation. What you get paid for and what you're good at is your profession. And what you're good at and what you love is your passion. And in the center of it is you. And I'm here to tell you that each one of you have to find out the you of that Ikigai and what defines you. And that's different for each one of us in the way we look at it. So I want all of you all here to be original, think original. And this is my last video. I'm ending with this and I promise to clear the stage out of this. Amrita, this is a promise for me. But it's an interesting video.
If you have an idea that you genuinely think is good, don't let some idiot talk you out of it. We had already done the Fantastic Four and I think maybe the X-Men, I can't remember the order, but my publisher came to me and he said, Stan, I want you to come up with another superhero. So I said, okay, I went home and when my publisher said do something, I'd better do it because I wanted to keep my job. I thought, what can I come up with now? Well, the most important thing in a superhero at first is the superpower. Once you get that, everything else comes along. So I thought, what power will I give a new guy? And I saw a fly crawling on the wall. And I said, hey, if I can get a superhero that could stick to walls and crawl on them, man, that would be cool. So I thought that was good. Now I needed a name. So I go, let's see, Fly Man, Mosquito Man. And I got down to Spider-Man. Spider-Man. It just sounded dramatic. So, okay, I had my hero, I had his power, his name, and then I figured just for fun, I'm going to give him personal problems. Because except for you people who are perfect, your lives are perfect, but most other people have personal problems. And then I thought I'd make him a teenager, because there were no teenage superheroes that I know of at the time. So armed with all that wonderful material, those great ideas, I ran into my publisher's office and I told him, this was my reaction, the reaction he gave me. Stan, that is the worst idea I ever. First of all, and he started to give me, because he's a very logical man, very intellectual. First of all, people hate spiders, so you can't call a hero Spider-Man. You want him to be a teenager? Teenagers can only be sidekicks. And you want him to have personal problems. Stan, don't you know what a superhero is? They don't have personal problems. Well, I left the office disappointed, but obviously a much wiser man. And I couldn't get Spider-Man out of my system. So we were about to kill a magazine. I think it was called Amazing Fantasy. It wasn't selling well, and we were sending the last issue to press. When you do the last issue of a magazine, nobody cares what you put in it because the book is dying. Just to get it out of my system, I put Spider-Man in Amazing Fantasy, featured him on the cover, forgot about it. A month later, all the sales figures came in. My publisher came racing into my office. Stan, you remember that character we both loved so much, Spider-Man? Let's do him as a series. Now, why am I telling you this? Besides the fact that I have to kill a little time. If you have an idea that you genuinely don't let some idiot talk you out. Now, but that doesn't mean you want something that means something to you. Try to do it, because I think you can only do your best work if you're doing what you want to do, and if you're doing it the way you think it should be done. Just do your thing, do it as well as you, that's the important thing. Don't shirk, whatever you do, give it your best shot. You'll be glad you did. Exactly.
Thank you.
On behalf of everyone present here, I would like to sincerely thank Dr. Rao for such a wonderfully thought-provoking session. Your insights today have certainly given us a lot to reflect on. I would like to call upon the stage Dr. Arun Alexander, the head of Department of Otorhinolaryngology, to felicitate Dr. Rao. I kindly request all the delegates to scan the QR code that is about to be displayed and fill the form. Thank you. Now, it gives me immense pride to introduce our third speaker of the day, Dr. Suresh David. Dr. David holds the distinction of being the first formally trained Indian physician in emergency medicine at a time when the specialty was still developing in the country. He founded the Department of Emergency Medicine at Christian Medical College, Vellore, which went on to become a model for emergency care and training in India. His contributions have played a key role in establishing emergency medicine as a recognized discipline in the Indian healthcare system. Dr. David is a respected academician and also author of several textbooks and publications in emergency medicine. These publications have helped train generations of physicians in the specialty. In recognition of his contributions, he was elected a Fellow of the Royal College of Physicians, London, and received the Leadership in Emergency Medicine citation from former President APJ Abdul Kalam. Through decades of work as a clinician, educator, and pioneer, Dr. David has left a lasting impact in emergency medicine care in India. Ladies and gentlemen, please join me in extending a warm welcome to Dr. Suresh David.
Very much. Could I have the presenter slide? Good morning. Thank you very much for that very enlightening introduction. While they are searching for the presenter, which I've received, I just want you to do an exercise with me. Those of you who are seated, could you please stand up for me? Please. Please stand up. Excellent. And can you all stand on your toes and stretch your arms? Good. Thank you. Please sit down. Just to make sure that your circulation to the brain is working very well, because we have been seated for too long. I'll wait for you guys to settle down. Can you hear me clearly? Yes or no? Can you hear me clearly? Can you hear me clearly? Great. Because I want this to be an interactive session. Okay? Please settle down. Thank you. I believe that we have 3,000 of you registered for this conference, CONNAISSANCE, which is its 8th version, which is happening now. But there are 30,000 medical students in India. Why is it that just 3,000 of you are here? It's because you are different. It's because you do things differently. And you are here to learn how to make a difference. Medical education is not easy. It's a very tough proposition. But you are tough. That's why you are in it and you will complete it. In the process of acquiring knowledge, you will come across many crossroads. And one of them, as a senior student or as an intern or even as a budding medical student, the thought will cross you, what next? You have reached a particular chapter in your life to be a trainee, and at the end of this training, what happens next? Crossroads is not a place where you get stuck. Crossroads are a place where you pause, look at the options, and then decide to move on. And let me tell you, sometimes we do make mistakes. we choose the wrong road. That's okay. It's not a problem. Because life is a very long journey, and sometimes we start off on the wrong road, but then we find our way eventually where we need to. So looking at that, I'm going to actually take you through an overview, which is going to talk about the history of emergency medicine. So as you would have known by now, I am an emergency physician. So I'm going to talk to you about the history of my specialty, how it has evolved in our country, and being Connaissance, being a research conference, I want to share with you what exactly are the options for research in the specialty. And finally, to take you through a thought process which will make you think if emergency medicine is an option for you. To begin with, how many of you, I know that you come from all over India, I want to have a show of hands. How many of you in your medical colleges still have the word casualty? Can I have a show of hands? Excellent. Thank you. I know this for a fact, that in many medical colleges, even the latest MCI rule says that you really don't need to have emergency medicine for undergraduate training. So therefore, I have to how exactly the specialty has grown. To begin with, the word casualty comes, it denotes those who have been wounded in the war. They were called as war casualties, and a collection of them where they were put together was known as the casualty ward. And it all started in the 12th century. In the 12th century, there were the crusades which were going on. And during that time, in Turkey and other such countries in the Mediterranean area, the knights who belonged to that area were called the Knights of St. John, and they were the ones who were setting up hospitals and care centers for those who were wounded in the war. And the place where they collected were called as the casualty ward. But subsequently, during the time of Napoleon's Surgeon General was known as Dominique Jeanlor. Now, Dominique Jeanlor was the one who invented a particular word which emergency even today. It's called the triage. Triage is a word, and Dominique was the person who showed that the sooner you treat the patients who are sicker, the better is the outcome. So that's how the first recorded features of emergency medicine came into existence. But as life went on, and they found that these casualty wards were more like a stop before death. And you will see that there is a priest who is standing there blessing, and there is a nun sister who is caring for patients. So it was a place where there was not much of hope. And that's Florence Nightingale planning a casualty ward. All these things were happening primarily with war and those wounded in as their primary targets. But eventually they realized that this is also from World War I, where Australian troops were bringing in their patients who were injured in the war, coming in from Australia, in the Vietnam and such areas during World War I. But there was a change which occurred because wars became less and less. I wouldn't say that right now at the present situation, but war wounded were surpassed by people by domestic emergencies. People, society, ones who were beginning to demonstrate there were more and more patients who required emergency care, and that required the need of having to transform. Can I have another one or some method by which I can change my slides? But this isn't moving too well. War surgeons who were there earlier they had to be transformed into casualty medical officers because these casualties were beginning more and more patients who had domestic emergencies. Give me another one, please. Or put the put this thing, computer up here, something like that, so that I can have control? It's not happening. Huh? Work ஆகலைங்க சரியா, அமுத்தின சரியா மூவ் ஆக மாட்டேங்குது. இன்னொன்று இருக்கா? Can you give me a laptop up here? Okay, the transformation basically, no. Originally, the so-called war surgeons were people who were general surgeons, because there was no separate orthopedics those days. General surgeons also did orthopedics, and they belonged to the association of surgeons and barbers. Barbers were the ones who were acting as surgeons. So obviously those people did not know much about non-surgical of any kind. So therefore they saw that the mortality rate was very high. So these patients used to die like flies. That is when there was in England a person by the name of I will tell you because I know my slides, I made them. There was a person by the name of James Platt who was sent by the Parliament, British Parliament, to investigate and find out what was the reason for such a high mortality which seemed to exist in these casualty wards. And what he realized was something which was very well known, and that those people who were looking after these patients did not know much about domestic emergencies and medical emergencies. So it was in 1962, based on the Platt report, that casualty was converted to accident and emergency, A&E. Even today in England, it is called as A&E. So it was in as late as 1962 it has happened. In 1967, they realized that it is not enough just to have people who are from other areas. People have to be specifically trained in emergencies. Only then the outcome was improved. So therefore, it was in 1967 that postgraduate training came into the UK, subsequently into Australia and into the United States of America. So earlier on, the old casualties, which I'm sure many of you would be posted in as interns, primarily they are run by medical officers without any specific training. And all that they would do is document the case which comes in and refer it to the appropriate departments. But the evolution and the transformation is such that today we assess the patients and we also initiate treatment. We start treating the patient while the patient is in the Department of Emergency Medicine. And the evolution basically resulted in the development of standardized treatment, because if each person decides to treat patients his or her own way, you can imagine the chaos that can happen, because people from different areas can come for training from different parts of the country or from even outside. So people who have undergone training in a particular institution, if they come in to work together, there is no standardization. So the first thing which happened was the development of standardized protocols. And the second was to enhance the collaboration between emergency medicine and other specialties. Earlier on, you refer the patient and they will do everything. But when there is a collaboration and a working together, that is when you are able to establish a very good rapport and establish the continuum of care. So specialty training came later, and subspecialties. Today, the evolvement has gone on to such that there are things like design medicine, wilderness medicine, toxicology, forensic medicine, scuba diving medicine, high altitude medicine, preventive emergency medicine. So many subspecialties have now developed. So where did I feature in all this? I started my career as a general surgeon. I was a surgeon, I trained, and I was working in CMC law. I came up to be an associate professor, but my interest was something else, because as a medical student and as a young trainee in surgery, I realized that one of the areas in patient care which was neglected was the early management of trauma. So my interest was in trauma, and I was working in a unit which was primarily a general surgical gastrointestinal surgical unit. So every day we used to see esophagus. That was our primary interest. So OPD was all esophageal cases referred to us. Our scrub list was all esophagectomies of different kinds. And our post-op reviews were all on esophagus. So after a few years, I got bored. And I wanted to pursue what my primary passion was, and that was the early management of trauma. And that is when I was trying to explore where I can undergo further training. And I realized that the Australasian College of Emergency Medicine had started in 1989. The program, the college started in 1989, and I went and joined them in 1991, 2 years after they had started the college. I was the first non-Australian to be joining the college, and they themselves were finding their footing, and they really didn't know what to do with an overseas graduate who says he wants to work only for 3 years, not interested in the degree, but he just wants to undergo training in emergency medicine and go back. So they let me do what I wanted to do. So I learned what I thought I needed in order to bring it back to India, because I was very clear. I was not going to settle overseas. I could have easily lived in Australia, but no, I wanted to come back to our India, and I wanted to do something for our people, for the population across the country who were suffering from lack of education, training, and care in the early management of trauma. So when I came back in 1997, when I came back in 1994, after 3 years of training, I was alone. There was nobody else. I was the only person in the country. And it was a long period till 1997 when I could not speak to anybody. Nobody knew even the spelling for emergency medicine because it was all casualty those days. So it was truly a very tough and a very challenging time when EM started in India. We were able to establish the first formally acclaimed and recognized training center for emergency medicine at CMC Bello. And it was in 1995, immediately 1 year later, I started a training program, not recognized by the Medical Council of India, but it was something that we had put together and we were doing in CMC. And also in 1997, I gave the first application to the Medical Council of India, as it was called then. Today it's called NMC. But for, for the Medical Council of India, I gave the first application to start the formal course for MD in emergency medicine. And it was subsequently in after 3 proposals, which I had to revise again and again and multiple trips to the MCI, it was in 2000. So look at the period of latency before we could start emergency medicine in our country. So since then, it's been very good, because if you look at India, yes, it was in 1994 when I returned back to India, when the American College of Physicians had me for the similar to a conference like this. There were more than 3,000 emergency physicians there. And they wanted me to speak. They allotted the topic for me, and they said, you speak on one emergency physician for 1 billion people. So that was my talk, which I had given over there. So from those days, today, yes, in 2009, we started with 3 seats at MCI. It was started in Ahmedabad, in the BJ Medical College. Of course, it has to be under the president of the Medical Council of India, his college, wherever he came from. So the first 3 seats for MD emergency medicine came out in 2009. Last year, 2025, there are about 9,000 emergency physicians in India today. And thank you. But actually the need for emergency physicians in India is, look at the numbers, 130,000 emergency physicians are required. So the job opportunities are plenty. There's a lot of options for people to do emergency medicine. What does the emergency medicine do? Today, the role of emergency medicine is to establishment is the establishment of what we call as the continuum of care. What we do are we are passing the baton. We receive patients, we run the course of stabilizing the patient if they are unstable, making a working diagnosis if required, starting the treatment that is required, and then subsequently handing over the patients to the concerned departments to continue the care. There is a seamless continuum which is established. So that exactly is the role of an emergency physician. So basically, looking at it, yes, we wear many hats. Yes, we wear many hats, and we are not just a plain doctor, because patients come to us at different stages. First, counselor. We get all kinds of patients. We are patients, we are counselors even for young people, college students who come to us in distress, psychological, mental trauma, their physical trauma. Many of them are assaulted. Especially today, recreational drugs are a very big problem for us. Patients come to us, especially women patients, come to us having been a victim of recreational drugs, either intentionally or accidentally. So we are a counselor in many ways. We're also a bad news breaker. Lots of deaths or very sick patients come to the emergency department, and we have to talk to the relatives and tell them and show them what the problem actually is. And many of these are not patients, they are people. They have never had significant problems, or they might have had some lifestyle diseases, but they come in with problems which has brought them to a hospital as an inpatient for the very first time. So therefore, we see and we break the news, the bad news, and we are also sometimes a silent companion, especially in times of grief. I remember there was this patient who was brought in after a road accident. He was brought dead on arrival. He was riding a motorcycle, he was brought dead on arrival. So I had to call the wife and tell her that she needs to come to the hospital immediately. But she knew, and she asked me the question directly, how is my husband? And I had to tell her, I have to tell you that your husband has died. So when she came in, I spent a lot of time basically sitting with her and listening to her. She was ventilating, and that's the way she was accepting the news. I didn't have to talk much. I just needed to be there. And she was telling me what's going to happen to my two children. One is in the 5th standard, the other in the 2nd standard. So sometimes that is our role. We need to give time for that. So we are more than doctors. We do multiple things. And yes, we are a source of strength for a lot of people who think that they are invincible, who think they're strong, they're powerful, but when they come to us at their weakest moments in their lives, at that time they need to see a source of confidence, a source of hope. And that's what we are. So our roles are multiple and many and are very challenging. We also deal with a very wide field. We are the jack of all trades. We look at everything possible, but we are the masters in resuscitation. So I remember very clearly when we were doing rounds one day, when there was a patient who was under the Department of Oncology. The patient came in, oncology team was also there. We were doing rounds, and that's when the patient crashed. He went in for an arrest. The team moved out and said, please take over. You are at this. So we are the masters of resuscitation. Nobody knows it better than us because we do it every day. So that is our role. In healthcare, you look at 3 things. You look at preventive care, you look at definitive care, and you also look at emergency care. These are the 3 cogwheels which need to move in society smoothly and work with each other, and only then holistic healthcare is developed, and we form a very, very important part of the healthcare system. And there are many facets for emergency medicine. Very interesting. One is, as I said, we play on a very wide clinical field. And for those who are not interested in a very wide field, I would rather work in a small field where, because the brain is such that it narrows it down as much as possible. You do your MBBS, where you study all subjects, and then after that, you will do general medicine, where you learn about medicine, and you have already eliminated surgery, orthopedics, gynecology, pediatrics, and everything. And then from there, you want to branch off into neurology, because you want to become narrower, narrower, and narrower. So the brain always wants you to do that. But emergency medicine is different. You play in a very wide field. And that is lovely for us. And we work with young people. Yes, young people are the ones who are drawn towards emergency medicine, and most of the people who are with us are very, very young. It's a young specialty. It started only in 2009. So you can imagine, everybody is young, everybody is fit, everybody is sharp. So I say there are only two kinds of us. There are young people like me, and there are younger people. So we have only two kinds of people in our specialty. We have an ample scope for research, and I wanted you to know that. And also, we are a teacher and an influencer. Our department in Karad, Maharashtra, where I go there for mentoring now, I don't work full-time. I've stopped working full-time. I do only part-time work. And I go there, and I'm a teacher and an influencer. So I talk to students. Medical students are my favorite. I never miss an opportunity to talk to them every month when I go. I always speak to students and to interns. Because to me, you people are like a freshly plowed field. I just need to throw the seeds, and you will grow, flourish, and you will provide hundredfold to our country. That's what I believe. You are the future of medicine of our country. Emergency medicine looks at basically patient care, it looks at education, and it looks at research. I put these three because these are the three-pronged approach through which we as administrators look at a department. The progress of a department, the development of a department and its faculty looks at these three facets: patient, education, and research. Most importantly, we are frontline soldiers. We are fighting fit. We are like the Red Berets, the Navy SEALs, SWAT team, which is what you're all familiar with. Or in India, we have the Rapid Action Force. We are fighting fit. We are there when there's a problem. And all have a common enemy, which is disease. So therefore, not only do we need to be fit in knowledge, we also need to be fit physically, because it's a very demanding field. During coffee break, Amrita was there and Shubha was there, and she told, "Why don't you sit down?" I said, "I don't want to sit down. I'm not used to sitting. I've been used to standing all my life. As a surgeon, I stood. Then as an emergency physician, I stood all the time, every day, 8 hours. So we have to be fit, mind, body, and spirit. So that is the requirement for my specialty of emergency medicine. Come on. Yes. And that's my band of warriors, my SWAT team in Karad. We took this picture recently. You can see all my team members over there. So I'm going to talk about research possibilities. As I said, this is a research conference, so I need to talk about clinical, laboratory, community-based, medical education. All these facets are there for us for research. So, and research is a very, very important component. I believe it is very, very important because in America, they will see 5 patients and in the textbook, we read that and we treat 50,000 patients. Why? We should be writing the books after having seen 50,000 patients, and they should read it and they should treat their 5 patients. It is possible. And that's what we should be doing. So I've been very passionate about contributing to literature. As I said, that's one of the things that I do now. I have already published 3 books, and the 4th one is now being written by the authors as we speak. We are hoping to complete it by the end of this year. And that's going to be a different kind of a book. Because all this while you have been studying a disease-led chapter. You will read about anthrax, you will read about sepsis, or in surgery, you will read about hernia. So it's a disease-based problem. It's disease-led chapters. But the book that we are writing is different. It's going to be problem-based, because in my specialty, most challenging and gratifying are patients whom we call as the undifferentiated patients, which means the patient doesn't come saying, I have cancer esophagus. They come in saying, I don't know, I've been losing weight. So therefore, from that onwards, we start trying to figure out what the problem is. So problem-based approach. So my 4th book, which I'm writing now, is not disease-based, it is problem-based. So there's a lot of scope for that. Clinical research, you can do any amount of clinical. I'm going to show you some of the work that that's going on right now in the department. Laboratory work, yes. Community-based, yes. Community-based, because I was interested myself in one particular question. What happens to the family behind the patient who is in front of me? That was a question which I was toying with. And I decided I will investigate and find out what happens, what is the physical, the mental, the spiritual, the social, the financial effect on the family to the patient who was presented with an acute health crisis. And that formed the basis of my research, which I used PhD. And my PhD actually was studying 100,000 people in a community. So I used the help of social workers to study with a questionnaire to look at what happens to 100,000 people when they have a problem. So there's a lot of scope. These are all the research projects which are going on in my department. One is, as you can see, there's a point of care ultrasound. I had visited your emergency department. All the trainees are very adept in bedside ultrasonography. So that's a very good scope for research. There's traumatic brain injury. There is a patient, there are people who come in with strokes, and we're looking at serum uric acid levels in these patients. Organophosphate poisoning, very common here in Pondicherry, in Vellore, and in most parts of our country wherever there is agriculture. These are all projects which are now going on presently in my department. I just made a list of them. Snake bite, I think I missed something on that side, doesn't really matter. Come on, yes. Acute dizziness, sepsis, aspiration pneumonitis, so many things, okay. So I'm going to ask you now, come to the 3rd part of my talk, which is, how do you actually decide? Because I'm sure you're at the crossroads thinking, which post-graduation should I pursue? Which course should I pursue? Although the NEET actually helps in a large way to decide what your performance is going to decide. But in your heart, what do you desire? How do you decide that you're going to choose a particular field to do your postgraduate studies? First of all is you get good marks, right? When you get good marks, you feel good about that subject and you think whether that can be a possibility to pursue your postgraduate studies. A bit slow. Second is, it's so glamorous. You see so many people who are glamorous in their departments. So many patients are waiting to see them, and everything about them seems good, and the subject seems to be very glamorous. The other one is, yes, you can relate with some subjects, and you can't relate with certain subjects because your personality also designs and decides what kind of work you would like to do for the rest of your life. How often have you seen this, where you like a particular teacher and you decide, I want to be like him, I want to be like her? How many of you have felt that way? Can I have a show of hands? Yes, yes, you see? Exactly. So therefore, these are all some of the very interesting ways. But I'm going to tell you one more which is not in the list. And that is my second son. I've been blessed by being a teacher for both my sons. One went on to pursue emergency medicine, and he is an associate professor of emergency medicine. The second son, he was more interested in better things in life, sport. He was a basketball player, university player. He used to play music. He was in drama, everything. He was a very bad student. So bad that quite often I was called. I was at that time the director of my institution in Kerala. So the physiology teacher would call me and say, sir, I know that you are my director, but I want you in my office now. I said, I'm coming. I know what it is. Coming. So I would go there. And then she would tell me, how bad your son is, sir. I said, what has he done this time? What's the problem? Sir, he is sleeping, sitting in the front row and he's sleeping. He should sit at the back because he's tall, but I have taken him from there and put him in the front. Even in the front, he is sleeping. So of course, he's standing near the door. So I said, please call him. Come in. So I had to ask him, so what exactly is the problem? Why are you sitting in the front row and sleeping? And he said, see, I am playing basketball from 5 o'clock till 7:30, 8 o'clock. Then I'm teaching. I'm the coach for the women's team of basketball. So that coaching goes till around 11 o'clock in the night. So I'm not getting enough sleep. So I said, this is the. Now this went on for every year. I mean, he was never a good student. But he was a very, very good intern. Excellent intern he was. He was so good that heads of departments used to ask me, which branch is he going to take? He should take obstetrics. He should take pediatrics. He's very, very good. I said, I know, because I've gone on rounds at 6 o'clock in the evening and I'm seeing him carrying a baby, all mummified, holding in his hand and writing his intern's records. And I've asked him, why are you doing that? He said, I'm giving the mother some rest. Oh, I didn't have an answer for that. So he was a very compassionate, excellent intern. So he kept everybody in suspense as to what he was going to do. So finally I had to ask him, so what are you planning to do? He said, I was such a bad student that I now have decided I want to be the best of teachers. And I want to teach the subject which I was poorest in, and that was pharmacology. How many of you love pharmacology? I see only 2 hands. Oh, some more are coming up. Anyway, so he went on. He's now today an assistant professor in pharmacology. He teaches pharmacology. So sometimes you choose a career because you want to make a difference. He says, I want to teach pharmacology so that my students will fall in love with pharmacology. So sometimes that can also be a reason why you pick a subject. So to begin with, you want to know whether you want to do preclinical or paraclinical or clinical, or you might decide to do administrative work. You may want to do public service commission, or you may want to, like Vishal was talking about, you may want to do research full-time. Full-time research is very good. There are a lot of people who do that, especially if you have for it. My own younger brother, he did medicine. Then he did PhD straight away. He went into PhD into a subject which is called as molecular biophysics. Have you heard of that? Molecular biophysics. So I had never heard of it. So he was doing this PhD between Indian Institute of Science and CMC Bangalore. So he had 2 guides. So I asked him one day, so what exactly is this molecular biophysics? He said, it's actually the We study the spatial configuration of the molecules, the way they are, and we try to manipulate. And by manipulating their spatiality, not special, spatiality, we then change their properties. So whatever is bad can be made good. Actually, he did it right. Because, of course, what he talked about, nobody. The Indian systems here did not support him. Of course, he was picked up by Harvard. He went to Harvard, then he went to Kansas, and then he was a tenured professor in the University of Minneapolis. Then finally decided he will break out. He broke out and he invented an adjuvant for the vaccine. And he supplied it to India. And those of you who received the COVID vaccine, one among the 30 million people, they all received vaccine, which was actually COVID vaccine, which was developed by Hyderabad, which had the adjuvant which my brother had given. So yes, if you have a passion for that kind of work, you should do that. So I am here to just talk about this specialty. What do you see? I want a response. What do you see? Yeah? Come on, loud, clear. Zebra, that's very good. She's very smart. She has seen the zebra. You see, actually there is a zebra and that's a shadow of the zebra. Yeah. Sometimes things are not what they appear to be. Okay. What is obvious is the shadow we see and we think there are a whole lot of horses which are walking by. Actually, no. They're zebras. So the reason I put this picture up is to let you know that sometimes things are not what they appear to be. Why do I say that? When you're swayed by some of those reasons why you made your choices, it is much later that you discover that it is not what you thought it was. That's what happened to me. I mean, my first love was surgery. I lived and breathed surgery. I was very good. I knew that. I taught well. I operated well. I knew my academics well. While I was a postgraduate trainee, I had already published a paper in surgery. But things were not what they appeared to be. So I changed my courses. I changed my course. I changed my career. So it's never too late. Sometimes you pursue what you think is best for you, but it's never too late to change what you want to do. Now, I'm going to ask you some questions, okay, which will help you to understand yourself a little better, okay? What do you see? Come on. What do you see? Can you see? Come on, it's so obvious. There's no trick in this. It's a biker, right? He's a biker, he's taking a curb. How many of you ride bikes? Can I have a show of hands? Yes, not too many on the top. Okay, you sit pillion, I presume, even if you're riding. So would you like to go around a bend like this one, like a curve? Yes? Would you like that? Or would you prefer this? Okay? So that leaves you with the question, which one do you prefer? How many of you prefer the one on the hill road, on the Ghat road? Show of hands. Okay. How many of you prefer the straight road? Show of hands. Okay, good. See, this indicates that if you are a person who prefers the straight road, emergency medicine is not for you. Okay, why? Because when the door opens, you don't know what the patient has got. You should be prepared to say, yes, I am ready, whatever it may be. But if you're a person, I would prefer to see only children coming in. Or if you say, I would prefer to see only people with diabetes coming in, then you're a person who likes predictability. Emergency medicine is not meant for those who prefer predictability, because you never know what's going to come through the door, at least today. Until EMS is so well established, the pre-hospital care communication systems are so well established that we have a prior information about what the ambulance is bringing us. So until then, no. Next question. What are you? That means, what exactly is your preference? It's player. That means you sit, you think, you plan, you deliberate your moves, you think ahead, and then you take your time to plan what you're going to do. Or, oh, okay, I've got a leash. I'm like a dog on a very short leash. I need to be right here. Okay. Yes. Would you like to play basketball? Okay. Teamwork, fast game, 40 minutes, everything done. Go home. That's it. Come back the next day. Which one are you? How many of you like chess? Show me your hands. Good. Excellent. How many of you like basketball? Okay, lots of people. Okay, which means you should pick something which you like to work as a team. Okay? Those don't take things like pathology, because you'll be so lonely in that, because you'll be the only one, you and your microscope and no one else. So take something where you're working with a group of people and work together. So those who only prefer to play chess and don't like to play as a team, emergency medicine, no. Never. Okay? Next. Who decides your career? Quite often, people tell me, sir, I'm willing to do whatever my spouse, my would-be spouse, wants me to do. Or I'm happy to do whatever my parents tell me to do. Or, I have a mentor, a guide, who has guided me right throughout my life. I listen to him and ask him for advice. Whatever he or she tells me, I'm happy to do. How many of you are of that kind? Show of hands. Nobody? You see, this process is called logging. Okay. Upstream, the logs are cut and then they are dropped into the water and they're held together. All you need to do is to hold them together. They will go downstream on their own. Okay. So that is how logging is. You know what this is? What's this? It's a fish. What fish? Dead fish. Yeah. I put this up because dead fish go with the flow. That is what happens to 90% of people. Okay. Because somebody is doing something, somebody told me to do this, and I believe this is going to be a very good future for me. That's what I was told. So you go with the flow. You prefer to take conventional specialties. On the other hand, these are salmon. Salmon going up miles and miles upstream, and they cross rivers. They go far, very, very far in order to reach their breeding grounds. Okay, breeding grounds is what they're all jumping to reach. But they are swimming against the flow. So what are you? Are you the dead fish which goes with the flow? Or are you willing to swim upstream? This is a very important thing, because suddenly if you tell, like you heard Vishal talk about how he does research, you want to go, or my brother that I was telling you about, suppose you want to go into research, people will ask you the question, why? You trained to do medicine, now you want to do research? Is that a good idea? I was asked this question from everybody, including the director of my institution. When I came back to India and said, I want to start an emergency medicine, he said, why? We've got a casualty which has been running like this for the last 100 years. Why do you want to make a change? And you are very good in surgery. You're a good teacher, you're a good operator, you're a good technician, you take care of patients well. Why do you want to change? It's because I want to not go with the flow. I want to swim upstream. So those of you who prefer to be conventional, stick to conventional fields. So having said this, what do you think I'm going to recommend to you? Is emergency medicine for you? What do you think? Come on. Yes? Very good. No. No. Don't do emergency medicine. It's not good for you. It's not predictable. Not good at all. There are multiple reasons why you should not choose it. There are only few people. They are freaks. They are different. They are the ones who choose emergency medicine. Okay? It's not meant for everybody. First and foremost, it is somebody who loves going around the curve. Okay? When you ask people, why do you, can I have an answer? Why did those of you who said you like to go around the curve, why? Please answer me loud. More? What? You feel more alive. Oh, I love that answer. What did you say? You said something? Exciting. Exactly. That's precisely what it is. These are all people who try to get their pulse up. We are adrenaline junkies. We are addicted to adrenaline. If I do not resuscitate, if I do not save a man's life, if I am not of help for somebody on one particular shift, I go home incomplete. Because we are certified adrenaline junkies. That's what we are. Okay. Second is, we love the challenge of the undifferentiated patient. Come on. Challenge me. Show me what you have, and I'll tell you what you have. I like that challenge. And my trainees and my associates love it. We like the challenge, undifferentiated patient, where we are the detectives. We find out what the problem is and we treat it. It's fantastic. I will get a 21-year-old girl brought in after a rave party, unconscious. I need to figure out what all is going wrong with her. Because if I don't fix her, she's going to die. Her respiratory rate is only 14. Not 14, sorry, 6. Okay? So if I don't fix her, she is going to die of respiratory depression immediately. So that's what I like. And that's what we like to have. Third is, we like to make decisions while standing at the bedside. Okay. We are not specialties like where, okay, I've seen in the OP today, I've sent all the investigations, come back and see me tomorrow. Or if I looked at some investigation and I know what it means, tonight I will go and sit and read and I will treat the patient tomorrow. I can do that, some specialties, which I don't want to name. But in mine is not like that. The decision has to be taken then and there. It was just about 2 months I had my first year resident who had joined 3 months ago. She was so good. In 3 months, there was this breathless man who had come in. She had a suspicion what it was because he had traveled from Spain and returned back. And he came back from Chennai airport, came straight to Vellore, and he came in with breathlessness. She knew what was going on. So she took the ultrasound, put it on his chest, and said, this is pulmonary embolism. Start treatment. 3 months into the course. So that is the challenge and that is the decision you need. And it was confirmed later on with CTPA, okay, which is pulmonary angiogram. So that is the amount of clinical acumen that you need to be sharp with. And this is what I say, we are fighting fit. We have to be so because we are frontliners And we need to be good intellectually, mentally, physically, in every way. Next. So I put this, this was the mark through which one of the candidates came in, which probably compared to JIPMER is nothing, but it's quite something that one of the candidates who came in here is very bright and very brilliant. Come on. No? No? I think it's tired of listening to my voice. Can you do something? Change the battery. Oh God. The green light is coming, which means the battery is okay, isn't it? No? I think it died. I think I'll come down, stand there. Huh? Is that better? Is that people cannot see me? I think it'll be a good idea for us to keep a laptop on the podium so we can operate it. Whatever. What is Johnson's law? Anybody? If something can go wrong, it will. Murphy's, not Johnson's, Murphy's, thank you. If something can go wrong, it will. So you've got to be patient. Yeah? Not yet. I think I'll come down and stand there and talk. You can't change the slide. I want to change it when I want to do it. Put the laptop up here. Thank you. Either do it immediately or I'll come down, one of the two. I don't want to keep them waiting. I'll come down. Shall I? Yes. That's what I told you, right? Because now wires, there are too many. For you to disconnect, it's very difficult. That's the one. That's my presentation. You're searching this one. Yeah. This doesn't change. Yes. Okay. Can I change? Yes. Okay. Thank you. So, as we were talking earlier, yes, we are all people who have very little patience to sit down in any place. So, chess is out of the question. We have to play basketball or some such high intensity games where we work together as a team. Where is it? Oh, okay. Finally, as I said earlier, we like to go home knowing that our presence has made a difference to a patient's outcome. So, can you hear me? Can you hear me? Yeah, good. Okay. Thrill of the unknown, yes. It's fascinating, okay? I'm going to talk about a few interesting cases which I have seen not too far away, not too long ago. So we had this patient who came, and she was a young 13-year-old lady who studies in class 8. I call everybody above the age of 8 as ladies because they have already started becoming ladies anyway, when they are 3 years old. So she studies in 8th standard, brought in by the teacher from the school, with history of abdominal pain. She handled it, but she couldn't. So the teacher saw, and she came in at 4 o'clock in the evening. She reached my department. So it was very close to the finishing of the class. So one of my residents took her inside to palpate her abdomen and everything, and she thought something was not right. So immediately she put the ultrasound probe. You see, ultrasound for us is like the stethoscope. Only thing is you can't hang it around your neck, but it's close by. So grabbed it, put it on that. Lo and behold, she was already in labor in second stage. Head was crowning. We brought in the delivery kit, which we always keep in the department. And by the time the parents arrived, all we had to say was, congratulations, here is the new addition to your family. So you see, life is like that for us in the emergency. We don't get patients, we get people. And what happened was that something which was very physiological which occurred. So she was not at all a patient. She was just a person who had the baby that she was going to have. Which one do I handle? This one. Okay. The next one was this engineer, very well educated young man who was electronic engineer from Assam. And he came in saying that I've got this wound which has been there for a while in the abdomen. It's been there for the last 10 days. It's not healing. Can you help? So we had a look at him, and just about 10 minutes after, we were just investigating, starting a line on him, getting things sorted out for him. 10 minutes later, we had this 2 people who came in and said, we are Black Cat Commandos. We have been chasing this man, and I believe he is in your department. Said, yes, we just seen him. So he is a terrorist. And then later on, when we went back to have a look at the wound, it was actually a bullet entry wound. He's a bullet inside him. So sometimes patients even, so he is an undifferentiated patient basically because he never told us what the problem was. So like that, we do have cases where there was this unconscious farmer who was brought in from the field. So the wife also came along because she had brought him along, and she said he was fine this morning. He went to work, but now it's summertime. This is now, about 2 weeks ago. So summer is on, so probably, he has not been drinking enough water. So we thought it's probably dehydration and heat stroke. Okay. So that's when we always keep in mind some differentials. And there was this smart cookie of my trainee who is like Sherlock Holmes. So she picked up a magnifying glass and she was studying the feet. And she said, sir, this is a snake bite. I can see the fang marks. So you see how heat stroke became snake bite, and we had to treat on a totally different line of management. So having said all this, very nice, challenging, very exciting, but there are certain downsides which you need to be aware of. First and foremost is what I call the glass house phenomenon. What we do is seen by everybody. The emergency department is a very important portal of entry for patients who seek medical help. So therefore, we are right there, and what we do is transparent to the entire society. And that's the reason our interaction with the community has to be very good, and it has to be frequent. We need to keep updating them. It's very easy for people to be found at fault in the emergency department. Unlike in some of the other departments, what goes on inside stays there. It doesn't come out. Okay? The second is that it's physically demanding. As I told you, yes, 8 hours of hard work really drains you in many ways, both physically, mentally, in every way. We were emergency physicians working here close to Pondicherry in 2004. I had brought a team when the tsunami hit us in 2004. We used to start work at 4 o'clock. We used to get 4 o'clock, leave Pondicherry. We were heading towards Tarangambadi where this has happened. the tsunami had struck maximum. And we used to work till 10 o'clock at night. So 10 o'clock we finish with dinner and debriefing of the whole day's activities. So therefore, it's very, very tough and very, very demanding if required. Not too many accolades. No. You work as an obstetrician, the whole ward gets chocolates, biscuits, laddus every time the baby is born. As a surgeon, we used to get so many people coming with gifts and sweets to eat because they're going home feeling well. Emergency department, no. You don't get any accolades. Very rarely. Very rarely. I still remember I was a final year resident of emergency medicine there in Adelaide, in Australia, when I had been on night shift, and about a week later, there was a man who came in very distinctive looking. He came in and said, "Who was the resident who resuscitated me a week ago?" So I said, "It's me, sir." I knew who he was because he was the head of cardiology. He's a Sri Lankan man, so not very built, big built, diminutive, but very, very powerful. He came, he showed me his chest, and he said, "Look, you have burnt my chest." I said, "Yes. I had to defibrillate you 18 times. So you do have burns." And he said, "Thank you." I said, "You're welcome." So these are the kind of accolades we get. Okay, so it's nothing fascinating. Shift work. Those of you who like 9 to 5, regular work, 5 days a week, not meant for you. Okay? But I love it because it gives me, I do afternoon shifts. I used to do afternoon shifts twice in the week. Mondays and Thursdays, I used to work in the afternoons. Even as a professor, I was working twice. I love it because those 2 days, Mondays and Thursdays, I do everything else. For the house, go to the bank, do many things which I cannot do if I finish my work at 5 or 6 in the evening. And I loved it. It was really, really nice. But those of you who prefer the 9 to 5, the conventional work, no, not suitable for you. Physician burnout. This happens. Okay? There is a particular component, especially, which is known as compassion fatigue. I want you to go and read about that. In fact, I was talking to the trainees of JIPMER today about compassion fatigue before I came in here. So this is something that people need to watch out. Those of you who aspire to do emergency medicine, you need to remember that this is something that you need to take care of. But having said all this, I told you that life is a very long, windy road. Okay? You are at the beginning of it. You have come a little bit, but then don't rush. Don't make up your minds 100% and say, "I will only do that, otherwise I'll die if I don't do that." No, don't. Because why do you want to rush? Now everybody wants to rush. The day you finish your internship, those of you especially who are from colleges outside, you can't think beyond internship other than to sit down and study for NEET. Don't be in a hurry. Life is a long road. If you have not yet made up your mind, if you feel that in your institution you have not obtained enough expertise in patient care, general patient care, if you have not done enough procedures, if you have not had the exposure to all the possible fields that medicine has to offer, don't be in a hurry. Take your time. Because remember, you must enjoy the journey. Don't rush. Final destination, everybody knows. What's the final destination? Huh? Death, exactly. Why do you want to run to it? Walk. Look around. Smell the roses. Enjoy the journey. You will get there anyway, whether you want it or not. So once again, for those who are at the crossroads, remember there are many things which you will be going through. I won't go near that speaker. Take your time. You remember the first picture I showed you? Remember, you're not there, you're not stuck. You're not in a dilemma. You are pausing. You are taking it all in. Why are you here? To explore options. That's why you have traveled. For those of you who are from JIPMER, that's okay. But those of you who have traveled and come from afar, you are here because you are thinking differently. You are giving thought to exploration. So take your time. Don't be in a hurry. And I want to leave you with one particular verse which is there in the Holy Bible. And that is, the harvest is ready, but the laborers are few. In my field, the harvest is ready in our country, but the laborers, as I told you, are few. So I want to wish you all the very best. Thank you for listening to me. I want God's blessings on you as you go ahead. Thank you, and Jai Hind. Question time. Does anybody have a question to ask? Anyone? Any question? Yes, I'll give you the mic. Hold on. I'll come there. No problem.
Good afternoon, sir. Thank you, sir, for such a wonderful session. I am Harini, final year student, sir. Sir, how do you handle controversial points during the teamwork? Like in emergency medicine, the decision should be very quick.
Yes.
During teamwork, how do you handle controversial ideas from your team?
Okay. Good question. Thank you for asking this, because excellent question. Thank you. No, keep it in case I haven't answered and you want sub questions. When we talk about teamwork, first and foremost, what we do is make sure that our protocols are all standardized. Okay. You take, for example, day before yesterday, we were actually resuscitating a patient who came in with a very significant trauma. He had broken his leg, compound open fracture, both bones were broken. He had lost a lot of blood because the major vessels were injured. He also had a head injury. He was under the influence of alcohol. He struck his head. His GCS was low. So here we have a patient who presented to us without telling us where it's hurting him, because his level of consciousness is low. So he cannot point me to where his problems was, okay, or problems are. So of course, we will assess the head, but head comes later. First, we need to stop the bleeding. Then we need to assess and see whether there is any concealed bleeding, which is going on, which is not obvious. The bleeding is of two kinds, okay, overt and covert. Okay, overt is where you can see it, and covert is where you can't see it. So put the ultrasound and you find that patient has got a splenic rupture. Okay, so therefore, the entire protocol of practically every case management is protocolized. So therefore, each person knows their role, what they're going to do, and there is always a team leader. I don't like the word team leader because nobody likes to be led, but people don't like being coordinated, isn't it? You don't like to be led. I'm a leader myself. Why should you lead me? Yeah, but I don't mind you coordinating me. So they have a team coordinator, and the team coordinator will stand at the foot end of the bed, because the head end is required for the person to intubate, IV lines to be started, ultrasound to be done. So you don't want the team leader or a team coordinator to be standing and obstructing. So the team coordinator stands at the foot end of the bed and directs everybody. So therefore, there is a person who coordinates, but each member is well trained to work as a team. So that's how there is no conflict. Conflict comes in when there are ethical issues which are not at the bedside, which are later on. Sometimes, you have a problem where, I'll give you an example, okay? I had this patient who came in with carcinoma esophagus, significant. He's already had radiation therapy, chemotherapy, and everything. And there was this patient who came in early in the morning. I'd just come into the hospital at 8 o'clock, and the patient rolled in, and he required to be intubated because, he was not breathing adequately. So intubated, then informed. Along with the resident from radiation therapy who was looking after that patient came the head of the department of radiation therapy. And he asked, why has this patient been resuscitated because we have given the DNR orders not to be resuscitated because it's end of life. I said, I don't have it. Have you typed it? Have you put it in the chart? Have you given a card to the relatives that's saying if he goes to the hospital that we cannot resuscitate him? He said, no. We are emergency physicians. Our job is to save lives unless there is a written directive, either by the patient who is brought in or by the doctors who have discussed and then given the directive that this patient is not for resuscitation. So unless that is there, we will be resuscitating. So sometimes there are these conflicts which can come. Then later on, we went back and I had my whole team sitting with me and they said, all you guys were there. What did you feel about it? It was fascinating to listen to some people who said, why did you resuscitate? My own team. Why did you resuscitate? Because this man, we are going to prolong his suffering. Is he going to come back to normal? No. I said, but how do I take a decision at that moment in time? There's no written directive. This has not been discussed with the patient or the family or with the doctors. We do not take such decisions. These are ethical issues which need to be deliberated and put down in paper. Until then, our job is to save lives. So sometimes we do have conflicts even within ourselves, but it happens in the room, in the conference room, not at the bedside. At the bedside, we are all clear what we are doing. Okay? Did it answer my question?
Clear.
You're welcome. Anyone else? Yeah. There, he wants.
Good afternoon, sir.
Good afternoon.
Good afternoon, everyone. Sir, my question.
What's your name? Which
Sir, I'm Harish Rana, third year medical student from HIMS Hassan, Karnataka.
From?
HIMS Hassan, Karnataka.
Hassan, yes.
Sir, it's like I have two-part question. One is the actual ground effect that this emergency medicine has in other parts of the country.
Okay.
Because the departments that are well established are doing well.
Yes.
But the ground reality in majority of the government hospital is that the work is offloaded onto the lower people.
Yes.
And at the end of the day, it is inexperienced interns who work at one of the most difficult shifts. There are night shifts.
100%.
And our college and various other colleges have these issues because of those inexperienced interns.
Yes.
So that's one question.
Yes.
The other is more philosophical, is where do you draw the line as a doctor?
Okay.
Like, because I feel like I can, if when I'm doing practice, I will leave everything for my patient.
Yes.
But also at certain time, we are human too.
Yes.
Where do you draw the line of this professionalism after beyond, okay, that's not my part?
Give me an example so that I will use that example to sort of illustrate.
Sir, this was our ATCOM class that they have initiated. So one of this example was that.
What's an ATCOM?
Sir, it's a new initiative for ethical studies for MBBS curriculum they added.
Okay.
So, sir, the example was that a patient came late at night, but the clinic was closed.
Okay.
And the doctor was sleeping up above.
Okay.
So, should the doctor wake up to help the patient or not? Such kind of decisions where you're like normally if in an IT sector, it's like our customer service is over, we can't help you.
I got it.
But as a doctor, where do you build that line?
I got the point. Thank you.
Thank you, sir.
The first one, what you said was actually a statement. And I 100% agree with you. And I'm not happy with the NMC, which made this decision that colleges which do not have postgraduate courses do not require to have an emergency department. That is unfortunate. Why they made the decision, I don't know. I don't go to the MCI or NMC anymore. But that, in my opinion, was not a wise decision. I think it is time to set up emergency departments all across the world, all across the country, all across all our hospitals, because care has to be standardized. The care that somebody will get from, say, JIPMER or from CMC or from Karad is not the same that happens in one of the government hospitals, because we have not equipped them with the personnel as well as the resources. So I lament with you that this is not standardized. So there's nothing that I can do about it at this stage. The second one that you asked is a very interesting question. Where do I draw the line? I'll give you an example. I had a patient when I was a final year resident. I was doing night shift. At 2 o'clock in the morning, I had this patient. He came to the emergency department. And in Australia, you do not discriminate anybody, send them home, nothing. Any patient who comes in, you have to see them in the emergency. The same thing with England also. So this patient came at 2 o'clock in the morning. He was triaged. And the triage nurse brought me the sheet with a smile on her face. She came and said, Suresh, you must have a look at this. I said, oh, okay. So I said, the triage notes was, patient has rash in his groin for the last 6 weeks. So I said, okay, call him in. So I said, so we had this problem for the last 6 weeks. One more question. Why did you decide to come at 2 o'clock in the morning? I was at the bar. I finished drinking for the night and I'm going home. I thought I'll stop by. What should I do? What should I do? I gave the instruction. Scratch stat. Review 9 a.m. in dermatology OPD. That's what I did. Whereas somebody comes and say breathless. Okay, I'm a known asthmatic, but somehow my medication is not working. It started at 9 o'clock in the morning. I thought I will manage with what I have. I have an escalation protocol which has been given to me, but I went through that. I still am breathless now at 2 o'clock. Will you call the doctor? Yeah. So therefore, when we need to ask for immediate or provide immediate medical assistance depends on the nature of the problem. So let the problem decide for you. It will become obvious. But remember, compassion is the foundation that you and I stand on. That should never be questioned. If a patient is seeking genuinely emergency help, we need to provide. Okay? Did I answer your question? Thank you. Anyone else? You have one more. I need to ask the bosses. Okay, can we have a few more questions? Is that okay? All right.
Good afternoon, sir. Myself Nileha from Kamineni, Hyderabad.
Yes.
Actually,
Kamineni, Hyderabad. There's a Kamineni in Bangalore? In Kamineni is only in Hyderabad, is it?
in Narkatpally.
Narkatpally.
Actually, I have a follow-up question for the question which the previous person asked.
Sure.
Like in case you said it becomes obvious where we have to prioritize, but in case where the physician is overworked, then isn't it like I'm also compromising the patient care because I'm not in the right mind to take a decision because I've been overworked
Yes.
for a long time?
Okay. Good question, actually, because let's say a patient has arrived, okay, in the department and needs care. Okay, not like the scratch stat one, but this is a patient who really requires care. That's why we have the so-called triage system. Okay, the triage, do you have a triage in your hospital? You do. So the triage nurse or the doctor who sits there are nurse-led triages, there is doctor-led triages also. They will decide which patient requires care at which time. So we have 3 priorities. Priority 1, which is red. Priority 2, which is yellow. Priority 3, which is green. So depending on the urgency, on the severity of the problem, patients are triaged into 3 zones and the patients are sent there. And the staffing of a good department is such that these 3 are based on a need-based analysis. Okay. if there is a department, let's say like JIPMER, which is very busy, you have more number of residents in the red zone because they are people, if I do not treat now, they will die. I have less number of residents in the yellow zone where there are patients who require care, and if I don't provide them within a reasonable period of time, they may die. Third is the green zone, where even if I treat the patient will not die. Okay? So therefore, depending on this, you triage these patients and put them into these respective areas. So therefore, patients get their treatment at the right time without any compromise, either to the staff or to the health of the patient. Okay? Did I answer your question? Okay. Yeah, you sit there, I'll come.
And sir, myself is Mahasni. I'm from Government Medical College, Jagityal, Telangana.
Where?
Jagityal. It's from in Telangana, sir.
Yes, where? Which part of Telangana? Near Chittoor or?
No.
Which side?
It's Karimnagar.
Karimnagar.
Near
So
Karimnagar.
you're closer towards that side.
Yes, sir.
Towards the Hyderabad. I mean the
First side of
that side.
Sir, I want you to give suggestions to a sensitive and empathic soul
Mhm.
who also interested in this emergency medicine.
Right.
Like, it's okay, but she'll get exhausted,
Yes.
right? She'll get
Yes.
exhausted, but she want to help people and create impact.
Yes.
But it's also affecting her on her personal level or individual level.
Yes.
How do you suggest her to create that boundaries in her headspace, sir?
I thought you get discouraged by showing you all the slides that I was, it was sort of a negative way that I was presenting, right? Showing when you should not do. But that seems to have had the effect that I wanted. Because here I have a person who's very sympathetic, empathetic, sensitive, but wants to help. Okay. Fantastic. And she wants to do emergency medicine. I will leave a role model for you. And the role model is Mother Teresa. Have you all heard of Mother Teresa? You have? Okay. Good. You got the mic with you? No? You're giving it away? Okay. Doesn't matter. I want to see, I'm sure all of you heard the question, and that's right. That's why I wanted to make sure that the question is heard. And I'm sure among the audience, there are many of you who actually will fall in line with Harini, no? Suhasini, sorry. You are sympathetic, you are empathetic, you're sensitive, you feel for the patient, but you're daunted by the fact that it is physically very demanding. Okay. And you're worried whether you will fit into that, because from what I was telling, each and every one of them seems to be an athlete. No, not really. The person that I will leave behind with you is somebody whom I also idolize a lot. Her name is Mother Teresa. I have worked with Mother Teresa in her home, which is in Calcutta. She started there first. And the mother has set up establishments and centers all over the world. I have also worked with them in Alice Springs in Australia when I was working there. Somebody came and asked her, Mother, you are so frail, you are so soft, but you work from 5 o'clock in the morning, you work till 8 o'clock in the night. What gives you that energy? What gives you that compassion? What gives you the drive and the perseverance to go on and on and on? You've been doing this for the last 30 years, but you haven't slowed down. Why? And how do you? What is the secret? And you know what she said? Does anybody know? No one. She said, I don't have a problem. I have uncontrollable amount of energy, unlimited amount of energy, because every person that I pick up who is dirty, who's diseased, who's smelling, whom I pick up from the gutters of Calcutta, every person that I pick up and look at, I see the face of Jesus. That's what she said. That is what drives her. Every patient, I tell my trainees, every patient that you pick up should be reflecting somebody whom you love. If you do that, you will automatically. How does somebody train to be a marathon runner? Are they born marathon runners? No. They undergo training. Okay. So you need to become physically fit. You need to become mentally and intellectually fit. You need to arm yourself with the knowledge, and you're ready to go. Because you know why? You have one characteristic which will facilitate this, and that is compassion. That compassion will drive you to achieve great things. Okay? All right. Did I answer your question? I'm coming.
Any suggestions, like any books to read so that to get to that mindset, or any lectures to listen if you have any idea? Like,
No books will teach you what people teach you.
okay.
For me, which I tell trainees to read is The Patient. The Patient is the best book God has provided you. Okay. You are in the field of medicine because you chose to look after human beings. Otherwise, you would be looking after computers, you'll be looking after buildings, you will be looking after automobiles. Okay. Or you could be looking after logbooks, accounts, or you could be teaching philosophy in a college. No. You chose to do what you wanted to do. And you will learn primarily from your patient. Treat each patient as a book. And I tell my students, you're not able to read the book because you are not understanding the language. What is the language? Knowledge. You need the language of knowledge to read the book, who is the patient. So that's what you need to do.
Okay, sir.
All other book reading, net reading, WhatsApp, Chat GPT, secondary. Chat GPT and AI can never replace the patient. Every patient is different. What is the difference between mathematics and medicine? In mathematics, 2 plus 2 is always 4. In biology, 2 plus 2 can be 4. That's the difference. Okay? So never forget the important book in your life.
Okay, sir. Thank you so much, sir.
Any more questions? Yeah, I'm coming. Coming. Ladies first. Is that okay with you? Somebody raised their hand there. Yes. Ladies first, you don't mind? Okay.
Good afternoon, sir. I'm Shiraja. I'm from TOMCH, Karnataka.
Where is it?
Attibele.
It's near Hosur.
Yeah.
Okay.
I'm studying in second year MBBS.
How nice.
Yeah. I wanted to know, like, how do you deal with the mental trauma of someone's death? Or do you get used to it? Because emergency medicine, you see a lot of
Yes.
death.
True. In emergency medicine, we see a lot of deaths. Okay. Seeing 3 deaths a day used to be a regular thing for me. Okay. This is where 2 things happen. One is we lose empathy. Okay. I want you to write down these words and I want you to go and read about them. I saw you are having a notebook in your hand. Write down the difference between sympathy and empathy. Okay. I want you, all of you as medical students, it's that mic, the speaker. I want all of you as medical students to learn the difference between sympathy and empathy. Okay. Second, I want you to go back and read about what I put up in my slide, which was compassion fatigue. Okay. Why do I want you to read about this? Because you have to protect yourself from that wall which you will build yourself. It's a very complicated sentence. You have to protect yourself from the wall that you're going to build around yourself. Nobody else is going to build the wall. The circumstances will facilitate you to build a defense mechanism which will not hinder your integrity and your mind. So you have to prevent yourself from that. And I can see Shubha standing right here telling me, get out. Okay, I saw that. I could read you. So go and read a little bit about that and try and understand. That's something that I always tell everybody who works in emergency. Prevent yourself from falling into the pit where you have a defense which makes you insensitive. The net result is we become insensitive. That should not happen. Compassion, as she said, should always be the foundation that we will stand firmly on. Okay, do not lose the compassion. And that's most important.
So, but isn't it easier if you're insensitive to treat a very...
No. No. You should never become insensitive. Why did you choose to do medicine? Because you care. You care for fellow human beings, not computers. You care for fellow human beings, and that care stands on compassion. That you must never lose. Yeah. Okay? Yeah.
Thank you.
You're welcome. Last question. Somebody over there. There you go. Yeah, you'll go. Okay.
Good afternoon, sir.
Good afternoon.
Praneeth, I'm from Hyderabad, sir.
Yes, Praneeth. Which college are you from?
Mamata Bajpalli.
Mamata?
Bajpalli, sir. It's in
Bajpalli.
Hyderabad.
Okay. It's in the city of Hyderabad?
Yeah, sir.
How many colleges are there in Hyderabad?
Then,
Many, yeah? Okay. Because I thought Pondicherry had the maximum, so 8 or 9. Hyderabad has even more. Okay.
actually, I have the exact same question the person asked, sir.
Okay.
So, actually don't know what to ask. But I also have a follow-up question that after you see many deaths in the casualties, sir, is there a chance that your brain...
Wait, I don't work in a casualty.
Oh, sorry. Emergency medicine. I'm sorry, sir.
Sorry, I pulled your leg. Yeah, go on.
When the doctors see a lot of deaths in emergency medicine, is there a chance that the brain gets numb? That if any chance they hear
True.
any deaths about
It happens.
their family members or their close relatives, any close people?
It does. See, the effect of this, I didn't want to go on because they're all going to drag me out now any minute. Give me 2 more minutes, Shubha. Okay. There are 2 ways by which we react to repeated impact which happens to the mind. Okay. I will share with you my personal experience. 2004, I was telling you I came to this part of Tamil Nadu. Did I tell you? I told you. I came here to work for tsunami. Okay. The tsunami occurred on the 24th. Okay. And I was traveling back home after Christmas holidays. I was coming back to Vellore. I was on the train when I came to know about this. So I reached Vellore at 6 o'clock in the evening. By 11 o'clock in the night, we were ready to deploy. 11 of us were heading out for on-site relief work, disaster management work here in Tharangambadi area. And we were stationed in Pondicherry, and we were traveling 30 kilometers every day towards Tharangambadi and coming back. Now, the first day when I went there, I was devastated with what I saw. And the first job that we set out to do was basically collect and dispose dead bodies. So our job from morning till afternoon was basically collecting dead bodies and putting them all into the deep pits which were dug by the JCBs just outside the villages. So we did this day after day, our morning first thing we were doing over the 3 days was doing this. Of course, every night we used to have a debriefing once we come back to Pondicherry and have our food, and then we used to sit down for debriefing. And people used to talk about this and how it affected them. Because by then it was quite late, okay, 3-4 days out in the sun, bodies which had been drowned. So you can imagine the state of the bodies and the stench and everything else which goes along with it. Yes, I was debriefing people, was trying to help them and everything else. But when I went back home, I never realized that I would have problems myself. Every night I used to wake up around 2 o'clock in the night, drenched in sweat, smelling the bodies, and saying, why am I here? I need to go, I need to work. There are bodies to be disposed. So my wife would know because, I was sitting up and I was restless and she'd say, what happened? Same thing. I said, yes, same thing. That went on for 6 months. Because I helped everybody, but I did not help myself. That is why it is important to understand the concept of compassion fatigue, to understand the concept of PTSD, post-traumatic stress disorder. I didn't treat myself adequately. So therefore, this is a condition which can affect emergency physicians, especially those who are in high acuity departments. You see death day in and day out, and you're handling with the relatives of these patients. You're empathizing with them. So therefore, it can have a cumulative effect on you, compounded by the fact that you're working hard. So you don't sleep enough. There's cumulative sleep disorder. So both these things together can have a significant impact. So we need to protect ourselves against that. And we have to actively do that. Okay? Yeah? All right. Okay. Thanks, everybody.
Thank you, Dr. David, for that excellent and interactive session. It was incredible learning about the vast field of emergency medicine from such an accomplished expert in the field. I now would like to call Mr. Steve, the organizing secretary of CONNAISSANCE, upon the stage to felicitate Dr. Suresh. That marks the end of the guest lectures for day one. I would like to thank every single delegate who attended today, and I hope that all of us can take something valuable out of today's discussions. A special thank you to Lata ma'am, Dr. Suma Balan, Dr. Vishal Rao, and Dr. Suresh David for taking the time out and discussing their topics in such wonderful detail. Before leaving, I request all the delegates to kindly fill the QR code and the G form. Delegates, a moment, please. The certificates for today's guest lectures will be distributed at 6:30 p.m. at the same venue.